thank you ever so much for the opportunity to be part of the meeting here today. I will try and share uh, our data dashboard, which we've been developing. It's not published yet, so haven't been able to circulate it, but I think it might be helpful to give us a bit of a sense of both the sort of the scale and the scope of migration across the region. I've said that like I could easily do it, and now I can't seem to be able to see it on the list of things that I can share. Ah, here we go. Now, when I'm sharing, I can't actually tell whether or not you can see anything on your screens. Can somebody just let me know if you're seeing?
Yes, we can see it, Roy.
Super. Okay. So what I thought would be helpful here is for us to just sort of get a sense within our southeast region. Here we can see that's our population, around 9.2 million people. I've picked out here the key migration schemes of particular concern, but we know that's not the only type of migration we get into the southeast. Classically, through people on worker visas and student visas, there's a much bigger population of migrants, which you can get from the ONS, and you can break that down by national insurance numbers and so on. But just to sort of remind us of where we are. So this our southeast region. I will come first to asylum, and so if I click onto my dashboard, and this will be available actually very soon. This tells us the number of supported asylum seekers in the southeast at the moment. If I hover over our screen, you can see where they are and where they are supported. What it gives us is a cumulative total here of people that are living in hotels, and I'll come on to that in a moment, and in contingency accommodation, because they're not all quite hotels. But it also adds in the number of people that are dispersed. That's a different part of asylum support, where you have more agency and independent living. If I put the hotel population on here, you can see here where we've got around about 6,000. That's a pretty dynamic figure. It changes every week. It's been as high as about 6,500 people, and over recent months it did dip down to below 6,000, largely driven by weather, I have to say, and the small boat arrival crossings being really important in determining the need and the use of asylum hotels. So it's very much in the public's kind of consciousness through the media coverage around hotels. I can actually, if you hover over here, you can see, where the hotels are located. That is now much more in the public domain. The stats are out there, not the names of hotels. That's important to say, but the sort of locations. If I hover over here, for example, this tiny place of Crawley, by comparison, you'll see 525 people in hotels. Very disproportionate if I come to Canterbury, where there are none, Dover, where there are none. I won't go through them all, but just to sort of, give you a flavour, where people are in hotel accommodation covers about 33 local authority areas, districts and boroughs, not counting county councils in here. But of course, we do need to be cognizant that there are county council functions that apply. So, it's wide across every part of the southeast. We have 70 local authorities in total, 63 if you take out the counties, and we've got hotels in, as I said, 33 of them. And the hotel population is growing at the moment. There was an exercise conducted over the summer called Project Maximise, and this was where the accommodation providers that run the asylum hotels, in our case, that's an organisation called Clear Springs Ready Homes. They has a contract with the Home Office to provide both initial accommodation and support to newly arrived asylum seekers. There's a statutory duty the Home Office has. They can't leave an asylum seeker destitute if they have no other form of support. So Clear Springs run the hotels. There are over 55 units of accommodation. Most of them, as I say, are hotels. They're not exclusively hotels. So we have, for example, over in Folkestone and Hythe, we have Napier Barracks. There are some units which are classified as supported accommodation, so they're independent living, but they still count as contingency. So what's the importance in that differentiation? Well, when people are in contingency hotels, they are supposed to move through quite quickly to the dispersal estate. Now, the Southeast has a relatively small dispersal number. We have around about 2,000 people in dispersal across the Southeast region. If you compare that nationally, it pales into insignificance, really, when you look at areas like the Northwest, Yorkshire and Humber, Glasgow. We have around about a sort of 6% share of when you compare it per ratio to our population. We would in times before the pandemic, there was an exercise that was conducted, which still applies actually, which was looking at achieving greater equity in asylum dispersal. The Southeast has a target to move from that 2,000 figure to 7,200 by the end of this year. That would mean that Clear Springs would have to be procuring a kind of 1,000 bed spaces a month now to get to anywhere near that target, and that isn't, in my opinion, very likely to happen. What that does mean is that we see proposals coming through for very large units of accommodation for dispersal. So that would include areas like permitted developments, centre town units of accommodation previously used perhaps for an office, a converted office block, which may house 200 or 300 people. We're not seeing that realised, I have to say, at the moment to that degree, but that is, that's very much a response to trying to really cope with the pressures of demand. Some would call it an accommodation crisis happening in this policy space for asylum seekers, adult asylum seekers. Peter's going to talk us through the Illegal Migration Act, which is fabulous. So I won't cover too much of an overlap there. But what it means for us in terms of provision of, say, large sites. There was one proposed for Bexhill, North Eye site. That's still proposed, but its use now may change from accommodation to detention. The Home Office issued a fact sheet along those lines. It means Project Maximise, which is, I'm sorry, I did talk about that, but I didn't actually tell you what it was, so my apologies. Project Maximise for hotels is when you look at the existing hotel estate and then Clear Springs examine that to see, actually, could we put more people in that space? Does the hotel have a safe and legal capacity that we are not utilising? Could we take out double beds and put single beds in so that we could put 2 people in the same room as opposed to be in a single room? That exercise took place over the summer, and it would uplift our hotel estate from that. If it was to be applied now, it would take us from about 6,000 that I showed you just now to around about 8,000, another couple of thousand people within that estate. Some hotels are bigger than others, some are tiny, but actually they've all had that exercise conducted by Clear Springs. So that's another way of accommodating people, coping with the accommodation crisis. One other way of doing that, which is very topical too, is that you take people out of the system, and you do that by serving decisions on them Now, the Prime Minister made a commitment to clear the legacy backlog of asylum seekers. And just for the avoidance of doubt, that legacy counts as people that were already in the asylum system prior to the Nationality and Borders Act being receiving royal assent in June last year, not the Illegal Migration Act, but that one. So people who were already in the system but had not had a decision on their asylum claim. So if you serve decisions on those people and you issue them, with that full and final decision, and in the main, we are talking here about positive decisions. If you receive a negative decision, you can appeal that and you can still continue to be supported. Taking people out of the system is largely serving positive decisions at this point. And we are beginning to see the impact of that. There's been a significant recruitment of asylum caseworkers. We know that there is a target to get to serving 1,000 decisions a week, and that will up to 2,500 a week by the end of the year. So when people get those decisions, of course, they then no longer are entitled to asylum support. They transit into mainstream benefits. So one of the impacts that we're seeing of that rapid increase in the asylum decision-making process is that people are presenting to local authorities as homeless. And there's been a change, not of policy, but of process that's accompanied this as well. The process would previously have been that Clear Springs, in our case, would issue people with 28 days notice to vacate their properties. Now, this is happening in dispersal and in hotels. Instead of 28 days, because that was, as I say, a process, not a policy, the policy states that people should receive a minimum of 7 days. And so what's happening is people receive, if you get an outcome on your asylum case, you will receive a letter from the Home Office which tells you in English that your asylum support will end after 28 days. And that is now when the clock starts ticking. So as long as the accommodation providers are able to give a minimum of 7 days, that's when, that's from that time that people really become very cognizant that they need to be. And the argument is actually they should be cognizant anyway because they would have received their letter. But of course, there is a lot of debate about whether a letter written in English in quite legalistic terms is fully understood. And sometimes it sits at the bottom of a pile of letters that their solicitors have and so on. But there's a big issue at the moment. I flag it now because, of course, we're talking in terms of homelessness, and a lot of people will not be seen in priority need and will potentially become, homeless in the areas where actually before hotels were introduced, weren't considered as asylum dispersal hotels. One of the asylum dispersal locations is one of the things for us to be aware of here. So I would say there are another sort of, there are other key issues around asylum, and I know it's not the only thing that we're talking about today. I think just to sort of flag up that the large scale sites, the hotel procurement, and the alternative sites, we are still having a lot of ongoing discussion about, and although we haven't in the southeast been proposed, for example, a barge like the Vicky Stockholm that is moored in the southwest at the moment, it's not beyond the realms of possibility that could happen. It could be in order to account for a crisis of accommodation, a rapid influx of the sort that we saw last October, November. We saw Manston processing site overwhelmed, but some sites being potentially identified for, we might call them tents or marquees or hard-sided structures is, I think, another term for that as well, which we're sure is a temporary position. So asylum, roughly, my thumbnail sketch, that's where we are in terms of adult asylum. let me come on to unaccompanied children. So we've got two figures down here. One is from the DfE, which is in the public domain, and there it is, which will give you the total of unaccompanied children across our region. And then we've got our figure where we update that, which is it's slightly more because it's more up to date than from 2022 from the DfE, and that's our figure from this year so far. The key things, which are happening, you're probably aware of Kent County Council's position. There was a court case which heard three things, and one of them was that Kent's position was unlawful in not discharging what was seen as their statutory duty to unaccompanied asylum-seeking children, and ceasing that activity, which they have done a couple of times. Actually, 2015 was the first time, but more recently than that, through sort of current small boat crisis. And the use of hotels was the second part of that, which was seen as illegal. And Brighton and Hove City Council, brought that case within there. Then Kent County Council are also within the sort of same legislative process, challenging the running, if you like, or even the whole kind of operation of the National Transfer Scheme for unaccompanied asylum-seeking children. So whilst that was happening with the use of hotels, we had hotels in the southeast. 6 of the 7 hotels that were used to accommodate unaccompanied asylum-seeking children were in our region, and 2 still are. 2 are still being used in Folkestone and Hyde. There were 2 in Eastbourne. There was 1 in Brighton and Hove and 1 in Oxfordshire. Officially, they are currently mothballed, apart from they're all mothballed by use of the Home Office, but the 2 in Kent are still being used by Kent County Council as it happens. So the children that we placed through the National Transfer Scheme at the Migration Partnership, we placed extremely quickly, actually. There is a protocol that underpins this, and it states that children should be transferred within 10 days if it's a local authority transfer. If it's a child from a hotel, should be within 5 days. And we've been making those transfers within around about 4 days. 3.5 was the quickest that we've been doing it, where we will allocate a child from largely it's from Kent, but there are other local authorities in the southeast that are over the allocation that or the figure that was seen as reasonable, 0.1% of unaccompanied children against your child population. If you exceed that, then you can transfer into the National Transfer Scheme. We've got 5 authorities that are currently over that, and we've got, I think it is, I've got it on this chart, but I think it's another 6 that are in between sort of 70 and 80% of that. So our capacity is not huge in the southeast at the moment. We are at 81% in total of the 0.1% capacity of the whole of the southeast child to unaccompanied asylum-seeking child ratio. But all referrals that we're making are being accepted and transferred really quickly. And I must say a huge thank you to local authorities that we work with in placing those children so quickly and safely through that process. So I will talk about this cumulative resettlement figure here. So resettlement, this doesn't include the Afghan resettlement schemes, but it does include the schemes that have been in operation, the UK resettlement schemes that have been in operation since Well, actually before 2015, but the one that we think of as really sort of, kind of galvanizing this was the Syrian vulnerable persons relocation scheme, which, where the UK committed to take 20,000 people as a result of that kind of, the crisis in Syria at the time. The highly vulnerable people, I have to say. So, that process for us was driven by pledges from local authorities. They were political pledges, actually. So each and every local authority, we had 74 back then, were asked to make a decision as to whether they would participate in that scheme and to what degree they would participate. And then we at the Migration Partnership would try to find matches when we were made aware of cases that were referred from the United Nations to the UK as meeting the UK's vulnerability criteria. So, about 10% of the total was settled in the southeast from the Syrian crisis. It's wider than Syria now. It's a global resettlement scheme, and it's been somewhat dwarfed recently by both the Afghan schemes as a result of Operation Pitting and the evacuation of Kabul, and it's again being rather overshadowed by the Homes for Ukraine scheme in terms of the sort of public consciousness. So let's go to the Afghan resettlement schemes, and you can see here the breakdown again. That's a total of a number of people that have come through both the what's called the ACRS, that's the Afghan Citizens Resettlement Scheme, and the Arab scheme, which is the scheme for people that had close connections to the military operation in Afghanistan. So we had 14 bridging hotels, and we are currently, this is where people who came to the UK, but we were not able to find a independent house, despite local authorities looking very, very hard for, because of the sheer volume of people that came over in that wave when Operation Pitting was in operation. And we had 14 bridging hotels up until the 1st of August, actually. And there were about 2,500 people living within those hotels. Now, the government made the decision that those hotels would close, and they have closed. We're now in a position where we're working with our local authority colleagues and partners to find accommodation for those people. And some have gone directly to accommodation. Those that meet the criteria can be accommodated in available excess MOD properties where the local authorities have taken those on. And others have been accommodated because local authorities have been able to find accommodation, and others have availed, other local authorities have availed themselves of a local authority housing allowance fund, which permits them to procure accommodation for a commitment for those that have come from Afghan bridging hotels, but also available for Ukrainians, and then long-term use for resident homeless, citizen homeless people. So that's the sort of position. It's been, quite challenging to say the least, with the condensed timeframes to get people accommodated, but we have had a very, very high degree of matching. And so we're now, our key concern is that those that have moved out of hotels but haven't got somewhere, who are residing in temporary accommodation, are matched and accommodated before the end of the year, which is the commitment that local authorities have made, where they have put forward local authority housing fund properties. So I will also give you the Homes for Ukraine figures here. These are very much in the public domain, and very much probably you'll just show you what you already know here, but it gives you the breakdown of where people are. We can, again, with this tool, take it down to district levels, take it to county levels, and we can take it to absolute numbers. You can do all sorts of witty things like show that as a share of the population and a share of the total. So, where it looks as if a local authority may, for example, not be having a huge amount. Actually, in terms of the population, it might be much more significant. So Host Ukraine goes on. We don't know yet about the future funding for that program for next year. We know, of course, that what was the existence for this year, and the authorities and the kind of people that have pledged their accommodation for people coming through that scheme. It's essentially a sponsorship scheme. It's not the only one in operation, but it's the only one of the sort of scale that we see here. And we've got to see how events, that sounds a terrible way to have the war, what happens there, because we've seen an ebb and flow of that number, but it's hovered around that 22,000 mark for some time now. Some people return, some people leave, come back, and sometimes new people join as well. There are issues around the kind of longevity of a sponsorship. In some cases, the initial commitment was only for people only asked for 6 months, and some sponsorships broke down much quicker than that. Some have lasted much longer than that. Some broke down before people even arrived. And in the end, of course, the local authority has a duty. Local authorities have a homelessness duty in the event that that sponsorships should break down. And then underneath here as well, on the Ukraine family schemes, there is a it hasn't changed its numbers, is it? So I might need to just review that. Forgive me. So we don't know from the family visa schemes where people are until we get feedback. Actually, there is no prerequisite for people to say where they're going if they come on the family visa schemes. And then Hong Kong. Let me just give you a quick picture of the position of Hong Kong. This has got the potential to be the biggest migration scheme of them all, actually. When the security bill was introduced in Hong Kong, the UK's response was, actually, we think this is very unsafe, and we will offer sanctuary in the UK for. It was really to qualify. You had to be kind of registered pre the initially pre the handover, but then actually that was extended, and up to 5 million people could come on that scheme. It hasn't been anything like 5 million people, but it's a significant number. That's the total that we have here. That's based on our kind of our mapping, which is not based on census because it doesn't cover that. There's no requirement for people to get registered. So it is really using community contacts that we have. We have 2 members of our team come from Hong Kong, have come through this scheme actually, and we've reached out, through their connections, through the community work that we do there, to get a good estimate, we think, of where people are. There again, issues. People come with no recourse to public funds. We are aware that there are people that are not approaching local authorities for support when they are falling on hard times, and there is a kind of, I suppose, a stereotype to think people that are coming through the Hong Kong schemes are more wealthy and have, independent financial means at their fingertips. To some degree, that's true, but it is by no means true of everybody. And there are instances of domestic violence and domestic abuse. And something else on this scheme, I think, for us to be really aware of is transnational repression. In most of the schemes that I've outlined here, when people come to the UK, there may be all sorts of challenges, and undoubtedly there are, but mostly they feel safe and they don't feel that they are still in danger of persecution. That is not the case for many people that are coming through this scheme. And we've seen instances in Southampton and in other parts of the southeast where it's become very, very obvious. But there are also some deep concerns about people from Hong Kong communities being targeted through, otherwise would be kind of regarded as quite prestigious, organisations like the Confucius Institute and so on. People being in areas that you wouldn't anticipate in public life. So kind of school WhatsApp groups being infiltrated try and find out where people are. People changing their names when they want to have social media contact. There's a deep-seated fear amongst many people from that community.
We've got about 2 minutes, Roy.
I was going to say that's it from me. So shall I give over and stop now? Over to you, folks.
That's wonderful. Thanks ever so much, Roy. Please do put any questions in the chat, and if we've got time later, we'll pick them up as we go along. But Roy, I think you're staying with us, aren't you? And we can cover things as we go through. But thanks ever so much. That's really helpful. Is there a timeline of when that data will be available publicly for us to play with?
Yeah, well, I say yes. We are hoping that by the end of the week we can get it onto our website. It's in the Tableau format at the moment, so not everybody has Tableau. Tableau is free to download, by the way, but some systems don't allow it. So we're just working with our IT bods to get that on our website. And there'll be two versions, I should say. One covers the publicly available data, and there is one which is available to key partners, but it's not publicly available. So we'll have that sitting behind a sort of password protected part of our website. That's brilliant. The techie bit, which I need to get sorted.
That's fantastic. Thank you. Thanks ever so much, Roy. We'll move on now to Peter Walsh, he's going to talk to us about the Illegal Migration Act. Thanks, Peter.
Thank you very much, Emma. I'm Peter. I'm a researcher at the Migration Observatory, which is a research institute at the University of Oxford that looks at UK immigration and migration policy. So I thought today I would just give a broad overview of the Illegal Migration Act and what I take to be its likely implications. Now, you'll recall that that was introduced to Parliament on the 7th of March of this year as a bill, and it flew through the House of Commons, as was to be expected, because the government has a large majority there, but faced quite substantial opposition in the House of Lords, where the government doesn't have a majority, largely because of the quite big complement of crossbench peers who don't have a political party affiliation. But the Lords, despite opposing quite large parts of the bill, really root and branch, really threatening to derail the whole thing, didn't press on with their amendments, because what tends to happen is they defer to the greater democratic legitimacy that's inherent in the fully elected lower house, the House of Commons being fully elected rather than appointed, as are the members of the House of Lords. So ultimately, the act that passed on to the statute book on the 20th of July was almost exactly the same as the bill presented to Parliament a few months before. So what is the Illegal Migration Act? It's the government's latest legislative attempt to tackle irregular migration to the UK, especially small boat arrivals. I say latest because, of course, we had the Nationality and Borders Act 2022. That's largely been superseded by this act. And I say legislative because alongside fundamental legal changes, the government does pursue policies of enforcement to try to reduce small boat arrivals. So sending money to the French, cooperating with the French, having our immigration officials and anti-crime agencies in France and so forth. Now, the act aims to reduce irregular migration by a very particular mechanism, and that's the mechanism of deterrence. And I'll return to the logic underpinning that and the evidence to support the efficacy of the deterrence approach later on. Now, I think, although it's quite long, I think it runs to 150 pages or so, the Illegal Migration Act is in one sense quite simple in that it tries to do one thing, I think, but do it as comprehensively as possible. And that one thing is simply to detain and remove all people arriving in the UK without authorization if they came from a safe third country, i.e. France. And under the legislation, it wouldn't matter if they're seeking asylum, and probably would have a valid asylum claim, as most small boat arrivals do. Most are successful, anywhere between 70 and 90%. And it wouldn't matter if they are a victim of modern slavery or they've been trafficked. Doesn't matter, they can still be detained and removed. That's what the legislation sets out to do. Now, not all asylum seekers are equal. They arrive in the UK via different routes. And depending on the route, they would or would not be caught by the provisions of the legislation. So when it comes to asylum seekers, those who are most definitely caught by the detain and remove power are, of course, those arriving via small boat or other irregular entry, not via normal ports. So that would be stowing away in lorries, hiding away in container ships, hiding in private vehicles, small planes, which not a lot of people talk about, but I suspect small boat arrivals might just be the tip of the iceberg, and the iceberg actually other types of irregular entry like small planes, general aviation, not very well policed. So it would include all of those. It would include those arriving on no documents or false documents at regular ports of entry, so airports and seaports, and it would include those arriving on valid visas. Most typically that would be a tourist visa because it's the cheapest, and then those individuals claim asylum in the airport, and that's because, according to the government, that entails deception about the purpose for which the visa was applied for. So that would also be caught. But there are two categories of asylum seeker who don't appear to be caught by the legislation. They are what's known in the business as surplus claimants. So these are individuals who are in the UK on a valid visa, say they're studying or working, and then conditions deteriorate back home, compelling them to make an asylum claim while they're still legally present in the UK. They're okay. A second group who are also okay are visa overstayers. So they were in the UK on a legal visa, they overstayed it, and then, say, on coming into contact with immigration enforcement, raise an asylum claim. Now, they're okay, surprisingly, because they also entered lawfully. Remember, the legislation is about irregular, unlawful entry, not presence. So they would appear to be okay as well. So, detain and remove. Let's look at the detention part of that first. First of all, who can be detained? Well, anyone. That includes pregnant women, it includes children in families, and it also includes unaccompanied children, though it does say in the Act that they can be detained only at the discretion of the Home Secretary. But we know historically where the Home Secretary has had such a discretionary power, she or he has used it. So I think we can absolutely expect unaccompanied children to be detained as well. Where will people be detained? There is a line to this effect in the Act: in any place the Home Secretary deems appropriate. I think that has to be interpreted broadly to include, of course, the existing detention estate, repurposed, disused military sites, maybe barges, maybe other buildings can be repurposed. I think we have to interpret that fairly broadly. How long can people be detained for? Well, at least 28 days, and of course, potentially indefinitely. The UK distinguishes itself in this regard. It's one of the few European countries that allows for indefinite immigration detention. Now, before the Act was passed, people could appeal to be released from immigration detention into the local community on immigration bail. But under the Act, they wouldn't be able to do that for the first 28 days of their detention. So in practice, it's going to be very difficult to remove people, for people to leave immigration detention within 28 days. The idea behind this 28-day period, by the way, is that in theory should give the government enough time to remove people. So they're working to that 28-day timescale. There are two exceptions to the detention provision. The first is for unaccompanied children. Now, they can be released on bail after 8 days. Doesn't mean they will be, but they can be. And the other exception is for pregnant women. So although pregnant women can be detained, they will not be able to be detained for more than 7 days. 7 days detention for pregnant women does require authorization by a minister. Ordinarily, it would be no more than 3 days. Now, I say that's the letter of the law. Of course, we know from experience that in practice, sometimes the government does break the law and it ends up detaining people longer than it should. And it has detained pregnant women for longer than it has been allowed to do so in the past. But that's what's in the law. So that's detention. Most people can be detained. What about removal? So here, only citizens of the EEA countries, that's the EU, Iceland, Liechtenstein, and Norway, Switzerland, and Albania, only they can be removed to their countries of nationality. Everyone else, and that's going to be the great majority of arrivals, they would have to be removed to a safe third country. There's only one safe third country with which we have such a returns arrangement. It's Rwanda. And it makes sense for those pretty much all nationalities to not be able to be sent back to their country of nationality, because, of course, under the legislation, the Home Secretary is going to be ignoring people's asylum claims. It's not going to be processing them. And if it doesn't hear people's asylum claims, it's not going to know whether it would be safe to return them to their country of origin. And in fact, when you look at the countries that people crossing in small boats come from, Afghanistan, Syria, Eritrea, you can well imagine that in most cases it absolutely would not be safe as a rule to return them to their country of nationality. So pretty much it's Rwanda for most people arriving by small boat, other irregular means. Who can be removed? Anyone, and that includes unaccompanied children, though the government will wait until they're the age of 18. And importantly, anyone arriving on or after the 7th of March of this year, which is when the bill was introduced to Parliament, if they entered irregularly and from a safe third country, i.e. France, they will never be able to get any kind of lawful immigration status. No leave to remain, no indefinite leave to remain, no refugee leave, no citizenship. So, for example, if a child were brought in, let's say a baby, 1 year old, in a small boat, they would have to live in the UK without any kind of immigration status. They'd still be able to go to school, they'd be entitled to primary health care, but no immigration status. And then when they're 18 years old, 17 years later, the government would then try to remove them to Rwanda or any other country with which we may have such a returns agreement. So that's detention, that's removal. Just to say a few remarks about the Refugee Convention. People often ask me, okay, but is this consistent with the Refugee Convention? And the custodians of the Refugee Convention, the UN, have come out and said in no uncertain terms, hang on a minute, this is an asylum ban. It's in flagrant breach of international law, which may be the case, but it's something of a moot point because there's no global police officer to enforce the Refugee Convention. That is to say, there's no dedicated international court to adjudicate on whether signatories to the convention have broken it. So, in other words, I think we can say countries are bound only in theory by the Refugee Convention, but not actually in practice. In other words, countries can get away with breaking the Refugee Convention, and there are many countries that do this. Now, that foray into the legal questions raised by the Act, I'm not going to develop it further, except to say that we expect all kinds of litigation to come out of this, all kinds of legal challenges, many of which I expect to be on the basis of human rights, right to liberty, right against inhuman degrading treatment, the kind that we often find in detention. But for me, the main focus has been on the practical challenges of the Act, and there are two. The first is, where are people going to be detained? The UK's detention estate currently has capacity for about 2,000 individuals. 1,500 of that capacity is used up. If the Act doesn't have its intended deterrent effect and people continue to enter the country in the tens of thousands, I think it's fairly clear that we're not going to have space to detain them. And that's an issue, because if you're threatening people with removal to Rwanda, I think you really need to detain them, because otherwise they'll say, I don't want any part of this, and they'll just disappear. They'll go underground. So that first part, there's a real challenge there about detention capacity. And it's difficult to expand the UK's detention estate. It takes a long time to build detention capacity. So there are real questions about that. The second is removal. Where are we going to remove tens of thousands of people to? I say tens of thousands. I'm assuming that the Act won't have its intended deterrent effect. And I'm assuming that Rwanda gets the green light. Let's assume that it does. Rwanda currently has capacity for about 200 or 300 individuals. If people continue to arrive in the tens of thousands, Rwanda would have to substantially increase their accommodation capacity. So there are questions as well, notwithstanding the Rwanda litigation, about where we'll be able to remove people to. If people are not deterred and we're not able to remove large numbers of people, then there's the real risk that the legislation will create quite a large perma backlog, is the term I've seen used. In other words, a large population of unremovable people, the vast majority of whom will be destitute and so entitled indefinitely to accommodation and asylum support in the UK. Now, I said that the rationale behind this Act is deterrence. What does the evidence say about that? Well, it suggests that deterrence policies don't have a particularly big impact on asylum decision making, on asylum migration and irregular migration, for two reasons. The first is that other things are much bigger drivers, like conditions in countries of origin. You think about war, civil or ethnic conflict, environmental disaster, poverty, those types of things. And also it's that prospective asylum seekers, refugees, they do not have a detailed knowledge of the policy that will await them in the UK or indeed any other destination country. And if they don't know about that policy, how can they be deterred by it? One caveat, which is that the available evidence on this is based on countries, including the UK, but other countries in Europe that haven't adopted policies that are quite so radical as what the government is pursuing with the Illegal Migration Act. So could it deter some people? Yes, it could. Of course, then there's always a challenge of knowing how many people it's deterred, because there are so many factors in play that drive this migration, and you can't control for all of them. And it's actually perfectly reasonable for the government to say, oh, small boat arrivals have gone up, but they would have been so much higher had we not introduced this policy. It's actually very difficult to contradict that. So, in sum, the Act will prevent the Home Office from processing people's asylum claims if they arrived without authorisation, most commonly by small boat. It will place a duty on the Home Secretary to detain and remove these individuals, primarily to safe third countries, i.e. Rwanda. And if people can't be removed, they would remain indefinitely in the UK without a legal immigration status, and people who are in this position and who are destitute would be eligible indefinitely for housing and asylum support. Now, a final thought on actually what's been implemented in the Act. There have been a few things, but the most important, the duty to detain and remove, is not yet in effect. For a very good reason, which is that the Home Secretary is not practically able to discharge that duty because she needs Rwanda to do so. And that's currently being litigated. It's being appealed by the government to the Supreme Court. And in my view, I mean, I think the whole Act really rests on the judgment of this court, because if the court agrees with the Court of Appeal that it's not safe to send people to Rwanda, then this really scuppers the entire Act. And it's very difficult to see how the government could continue with it without that safe third country, apparently safe third country, Rwanda, to send people to. So that's the Illegal Migration Act in a nutshell, and I'm happy to take any questions.
That was fantastic. Thanks, Peter. Utterly depressing, but fantastic in equal measure. And just understanding the nuances is really helpful, because I don't think I've ever heard it explained in such a simple way to really grasp the concept. So that's really helpful. Lisa, have you got a quick question?
Yes, a quick question. Thank you, Peter. That was amazing, very clear, really, really, really helpful to understand. Given that we've got a general election coming up and the likely delays with the legal challenges around Rwanda and other human rights challenges, is it reasonable to think that actually this act could be thrown out if there was a change of government?
Yes, it is very reasonable, because Keir Starmer himself has said we would not pursue Rwanda. Without Rwanda, you can't detain and remove people. That is the fundamental core of the entire act. So yes, absolutely. And I think that if you throw out Rwanda, it means throwing out the idea of sending our asylum seekers to other countries to be processed there under their systems.
Thank you.
Yeah.
And my second part of the question, very quickly, is with I work with Inclusion Health with asylum seekers across Surrey and the bordering areas around Crawley. So, but my question is, with the change to the status of the current people who've arrived after the bill, after the date in March or even June, are they effectively in political limbo until a change is made?
Yes, it looks that way. So the strange thing is, a part of the act has already been implemented. It's implemented retroactively. So it's already been passed. It's an act. It's received royal assent. But those arriving on or after the 7th of March, it's not possible for them to receive any kind of permission to stay. But so I think they're being considered as inadmissible at the moment. But the existing law is, okay, if we inadmissible, we're not going to hear the claim, we're going to try to remove you. If we don't remove you within a reasonable period, that's usually 6 months, then we will hear the claim. Now, I still see people going into the asylum backlog. Okay, fresh claims. The government is presumably ignoring them as inadmissible. There was a question of, well, in 6 months, will they hear them? But the contradiction there is, well, why would they hear them if there's already a law that says you can't give them any kind of status? So that's the thing that I actually I don't quite understand. That's just sitting there, this big contradiction. What is happening to these people? I think probably limbo is as good a term to apply as any, but there's a real lack of clarity. There's a real lack of clarity.
Thank you very much.
You're on mute, Em.
Sorry. We do need to move on. There is a question in the chat, but we'll pick that up as we go through, if that's okay. Sorry, Nancy, have you got one very quick question?
Just quickly, thank you, Peter. I work with unaccompanied children in Kent from a health point of view. So obviously I understand what the Act is saying around unaccompanied children. So are we saying then that new arrivals, who I presume will be treated as looked after children as they are at the moment, who will live with a local authority for their minority, they won't be able to claim asylum on arriving with us in Dover?
That's my understanding, yes. I mean, for the time being, I think they'll just be considered inadmissible, based on those rules that have been in place even before the Nationality and Borders Act. But I don't think there's a way under the current legislation that they could apply for asylum and get any kind of positive status.
Okay.
That's my understanding. Just Gillian Field quickly, there are no legal routes available for people from those countries, Iran, Syria, Iraq, Africa. They would have to be chosen to be resettled, and we're not really resettling anyone now, while millions of people need to be resettled worldwide. So I mean, the chances of being selected to be resettled are close to zero.
Wonderful.
I thought that was probably the answer, but I just wanted to check. Thank you.
There is the Afghan schemes, but we're not resettling anyone under those either. So
no.
And meanwhile there are 6 million Afghan refugees around the world. So again, pretty close to zero.
Thank you.
And on that wonderful note, I think we've got a short piece of lived experience video, if the technology works. Karen or Alec? There we go.
So question 1 is, when did you arrive in the UK and why did you seek asylum?
السؤال الأول: متى وصلت إلى المملكة المتحدة ولماذا قدمت اللجوء؟
أنا وصلت إلى المملكة المتحدة في يوم 9/2/2021. قدمت لجوء لحق تعرضت في بلدي للعبودية واستغلال والتعذيب من طرف حزب سياسي عذبني أنا وعائلتي بالتهديد بالاغتصاب بجميع أنواع التعذيب والاستغلال والعبودية.
I arrived to the UK on the 9th of February 2021, and the reason for seeking asylum is that I was subject to myself and my whole family to slavery, exploitation, and torture, and rape as well by politicians.
Okay, all right, thank you. And the second question is, what has your experience been since you arrived in the UK of the asylum process?
السؤال اللي بعده الثاني: كيف وجدت تجربتك في تقديم اللجوء في هذه البلد؟
صراحة كانت الخدمة بطيئة نوعا ما، ليست جيدة.
The experience was slow and it wasn't good.
Okay. And the third question is, how has us, the inclusion team, helped you since you arrived in the hotel?
السؤال الثالث بالنسبة لفريق العمل اللي هو نحن، كيف كانت تجربتك معهم في عندما قمنا بالتعامل معك في دخول الفندق وتسيير أمورك؟
الحمد لله، تجربة جيدة، ناس يشتغلون بمستوى عالي، تواصل جيد ومواعيد مضبوطة، ولكن لدي ملاحظة نوعا ما بسيطة جدا. أريد من فريق العمل أن يعمل على مشكل التواصل الاجتماعي، يكون عنده موقع في التواصل الاجتماعي عبر الانستغرام، الفيسبوك، الواتساب، الايميل، عشان تكون لو في خدمة في التواصل عبر شبكات التواصل الاجتماعي تكون الخدمة عاوتاني أفضل وأحسن. على العموم خدمة جيدة.
Generally, the services are very good, high standards, very punctual appointment. I'm happy with it. What I needed is that maybe if we can just facilitate communication and services. If I can follow you on any forum, so I can communicate with you easily. I suggest that in future. But generally, as I said, everything is fine.
Brilliant. Anything else?
No problem.
Oh, thank you.
Thank you, no problem.
Thank you. I think it just helps to have that fresh in our minds as we kind of hear more as the day goes on. I'm going to hand over to Olivia and Sarah now to give us a bit more about what's happening from an NHS and wider national context.
Thank you, Emma. Shall we introduce ourselves first and then we'll go into the presentation? So I'm Olivia Fagrag-Jones. I work for NHS England and I'm currently Deputy Director for the Migrant Healthcare Response with a particular coordinating role in the South East.
Good morning, everybody. I'm Sarah Rayford. I'm a public health consultant with the Office for Health Improvement and Disparities in the South East, and I lead on inclusion health portfolio South East.
So what we're going to try and do as a double act is take what Roy and Peter have mentioned and try to distill that into practical implementations for local systems. And I don't know whether you noticed in the clip we've just heard some of the translation around communication, which I only noticed today having listened to it a few times. The suggestions are around Facebook, WhatsApp and Instagram, and that didn't get translated, but it was actually quite clear. And I think there's a glimmer of hope in this, that this service user makes very clear that whilst his asylum journey and experience might not be great, actually what we can do in system in responding to some needs can improve that experience. So there's 3 parts to my bit of the presentation: setting the legislative framework in terms of access to healthcare, giving a sense of perspective and proportion in the way that Roy and has done as well, and then just some very practical reminders towards the end of it. So I'll go very quickly through the start of this, which is that the NHS legislation is fundamentally non-discriminatory, and there is a universal part to the NHS which covers primary care, so that's GP services, dental services in the community, pharmacy and optometry, as well as urgent and emergency care. And to access those services, there's no need to provide any kind of written evidence, whether it's proof of address, immigration status or ID. There are some liability for cost when it comes to secondary care services, but again, there are a number of groups, and we'll share the slides, that are excluded and exempt of all costs, all NHS charges. That includes refugees and their dependents, and asylum seekers and their dependents, but other groups are also part, and part of this network. We've focused on people who have no recourse to public fund, and sometimes no ability to prove that they have no recourse to public fund, and that's sometimes an issue. Oh, I'm not able to move the slides anymore. Are you able to move on, Alec, please?
Sorry, Olivia, are you able to take control in the top? Does it have that button at all for you?
Yes, it does.
Yep, there you go. You have control now.
Thank you very much. So in terms of giving a sense of perspective and proportion, when you work in a system, you have a cross-section of the whole population, and I was very pleased that Roy went through the different groups of asylum seekers and refugees, because in terms of numbers, asylum seekers who cross the channel by small boats are actually a very small proportion of migrants, and there's different bits on this slide. And whilst it's one of the top 5 priorities of the government, stopping the boats, within the asylum seeking group, they represent only 44% of that group. When you look at all the people who ask for visas and might be very temporarily or longer into the country, whether for work, study, visit, being with relatives, actually, again, it's a very tiny proportion. And even within the net migration count, they're very small proportion of people. So within your own systems, whilst some of these asylum seekers will be highly visible and it's highly politicized and mediatized, they are a small proportion of your whole population. But 1 in every 7 people living in the UK was born in another country. Again, Roy made some very salient point about people who have resettled from Hong Kong. And there's 2 points here, is that there will be a large group of people who might need some education in understanding how to access health and care, who may come from countries where there isn't a national health service, and therefore they don't know how or where to access services. And then there will be different kind of health needs depending on country of origin, either because of disease prevalence, because there are different health infrastructures, and some simple things like different immunization schedules. I just needed to say at this point that a lot of the infographics and some of the links here are from the migrant health guides that colleagues from OHID and UKHSA maintain and update regularly. And then what we need to do in health services is interpret this guidance into services. So health needs, some people might come to the very top when you're stratifying the health needs of your local populations and communities, and that might include asylum seekers but not be limited to asylum seekers. And then the final point around temporary housing, and there have been a couple of focus sessions on children and families in this group who are currently in B&B and urgent accommodation and temporary accommodation. But you can see on the graph here that current numbers of households and children within those households have surpassed the peak, I think, of 2003. So again, when you're looking at the needs of your local populations, rising to the top will be some large groups of people with similar needs. And I've borrowed this. This is the kind of infographics in terms of the purposes and the benefits of integrated care boards, and the reason why integrated care systems and boards were created by the Health and Care Act 2022. And I've borrowed them from Yorkshire, as I thought they were quite a nice representation, and we've got a presentation later on from colleagues. But the functions are to create more inclusive communities that address inequalities, improve health outcomes, but also other outcomes, and therefore all partners within systems, whether housing, education, voluntary agencies, are required to be together and deliver this. And Sarah will speak about inclusion health in more details. And by working together, it will probably be the only way to create sustainable and affordable services, where in the public sector there is a limited pot of funding that needs to stretch very far to meet the needs of all the people in the community. So just a few very practical reminders, and sometimes it's easier to see than to hear about them. There is a lot of support out there. NHS England has commissioned some bilingual guides and questionnaires. Doctors of the World, amongst others, the British Red Cross, Médecins Sans Frontières, also have all sorts of translated resources. The Safe Surgeries checklist, which is on screen, is a very simple reminder. Again, it's not necessarily just for migrants, it could be for anyone who might have a need for easy read, for instance, but they're really good reminders and helpful resources. And then I just wanted to pick up on dentistry, optometry and prescriptions, because I still get anecdotal reports from colleagues in this region, but across other regions of England as well, that asylum seekers, and again some other people who may have no recourse to public fund, are refused care or medication because they cannot provide proof of exemption. Very often that's well intended, because practitioners do not want people to be fined at a later date. And it is within contractual obligations to check that people are exempt. But there is also an option, and it's the red box on the prescription here, to tick a box to say, this person say they're exempt, but I haven't seen the evidence. In terms of asylum seekers and the Afghan refugees who were housed in hotels, large sites, barges, what we've been doing in terms of belt and braces is we're communicating the list and updated addresses to the business services authorities, so that people are not issued a fine if their address is one of those hotels or large sites. There is some guidance in terms of support to getting the exemption of healthcare cost. This has been archived, but I've just left it there in case it's still available. If you come across someone that hasn't yet been able to apply for an HC2, there's a number to call here. And then this is the same box, that's the dental care plan. And again, it's the same box for the dentist to say, no, I haven't seen this evidence, but care should not be refused on the basis of evidence not seen. So that's it from me in terms of hopefully putting some perspective and coming back to going away, I guess, from what is a really emotive and difficult topic, to thinking about how we can best address the needs of all the vulnerable people, but also the wider communities within our systems. Sarah, do I need to move on for you?
Yeah, I'll try and take control. Thanks, Olivia. See if that works. Hopefully that's moving on for people. So thank you, Olivia. I just wanted to add to Olivia's presentation with and setting the sort of context of what we're talking about today with vulnerable migrants within the wider sphere of inclusion health. So inclusion health groups are those, as you can see on the slide, so it includes vulnerable migrants like today, people experiencing homelessness and rough sleeping, Gypsy Roma traveller communities, sex workers, victims of modern slavery and human trafficking, and also people in contact with the criminal justice system. There are other groups that sometimes encompassed as part of that, but they're the main ones we're talking about when we talk about inclusion health. And essentially, inclusion health is a term used to describe people who are socially excluded. They usually experience multiple overlapping risk factors for poor health, and that might be poverty, violence and complex trauma. They're subject to stigma and discrimination, and they're not consistently accounted for in electronic databases, which can make it really challenging for systems to understand what their local area needs are and what the needs of those individuals are. They often experience insecure housing and barriers in access to healthcare and other services. And all of that leads to extremely poor health outcomes, which has been described as a cliff edge. And that can be seen on this slide. So this is looking at standardised mortality ratios and looking at deprivation initially, but also excluded groups too. And as you can see, for both men and women, there's a correlation between deprivation and mortality ratios. So those who live in least deprived areas are less likely to die than those who live in more deprived areas. And that in itself is shocking. But then when we add in excluded groups at the end, those the larger bars right at the end, you can see that people from excluded health groups are much more likely to die, and at an earlier age as well. And so coming back to the challenges faced by vulnerable migrants, and I know colleagues on the call today will kind of expand on a number of these things and work that's happening across the region and across the country. But just to touch on some of them, so as we've talked about, there's a long and complex immigration process, and people coming here for the first time and navigating a new culture and language, usually unable to work, multiple and overlapping risk factors for poor health, alongside poverty, poor housing. Children may have a delayed access to education, but all of that's within this sort of area of losing identity and status with a lack of family and community support. There's challenges around integration, racism, discrimination. They're extremely vulnerable and so at risk of exploitation, and then barriers to healthcare, as we've mentioned, in particular digital exclusion. But when we think about vulnerable migrants and then other inclusion health groups, there's a real overlap in needs between all of the groups within inclusion health. They very often have poorly controlled chronic conditions. They may have not been able to access preventative services or regular health services. And because of that, well, not because of that, but related, they have an increased risk of mental ill health, often in each of the inclusion health groups. There's a need to build trust between professionals and those communities and offering services which are culturally competent. There's often a need for specialist support services, and all of this needs to be delivered in a trauma-informed approach. So these principles are taken from the Inclusion Health Applying all our health guidance, which is on gov.uk. And this really talks about our principles for inclusion health. And this is at the different levels within services and the community. So thinking about frontline workers, the need to build trusted relationships, ensuring needs are met, but also professional development and developing that cultural competency. There's principles which can be put in place from a team manager point of view, so collaborating with other services, offering the highest quality standards, doing things differently, but also ensuring that your team has the right support and knowledge and training. And then finally, from a strategic and senior leadership point of view, it's really about raising awareness of inclusion health groups, trying to influence the system in terms of data, and really getting out there in front. And essentially, the message is that improving things for all inclusion health groups, migrants included, not only benefits the people within those groups, but also the health and care system as a whole. And so by tackling these inequalities, it supports the wider ambitions to reduce waiting times, delayed hospital discharges, and improving access to care, as well as reducing overall inequalities. And then finally, I just wanted to mention the legal duties that have been will come into play over recent months and years. So the NHS Act in 2006 was amended by the Health and Care Act last year, and that placed a statutory duty on ICBs to have regard to the need to reduce inequalities with respect to people's ability to access health services and reduce health inequalities with respect to the outcomes achieved for those individuals. There's also a duty to promote integration where this would reduce inequalities in access to service. And alongside this, then the public sector equality duty also obliges an ICB to have due regard to the need to advance the equality of opportunity between people who share a protected characteristic and those who don't. And so all of these duties together both allow and indeed require ICBs to consider the socioeconomic factors when determining health inequalities in their area and in adopting strategies to try and tackle or reduce them. That is it from me, so I'm going to stop.
That's
Or I
wonderful.
don't know, Alec, if you take back control.
Yeah, that's wonderful. I think really useful context there and some brilliant resources for people to tap into when the slides are shared afterwards. And if there are any questions, if you put them in the chat, we'll pick them up later in the day. We'll go straight over to Vicky, who's our last speaker before we go into a break for a short break, and who's our safeguarding guru, and he's fantastic. So over to you, Vicky.
Thanks. So I'm Vicky Gray. I'm the Regional Safeguarding Lead for NHS England for the South East region. And I noticed some fellow safeguarding gurus on the call today. So I'm delighted to see particularly Nancy and Jill on here as well. So I'm going to talk about safeguarding and the wellbeing of asylum seekers. So if you can move slide on, I think just to slightly rehearse, but not too much, the point there about the inclusion health. Is to be really clear. On my slides have disappeared, but I'll keep talking. You can all have the slide deck afterwards because I'm not going to read every single word that's on my slides. They're there for the detail is there for you. So hopefully while the slides are coming back up is that point about inclusion health, about those groups like sex workers, homeless people, people who've come into contact with the criminal justice system, etc., is the work that you're doing, a lot of people on this call, to address strategically and operationally the challenges and the issues that are faced by vulnerable migrants are transferable to those groups, that we don't look at people in silo, that actually some of these challenges and some of this really creative solution focused work that people are doing is really transferable across the systems for lots of different people who are disadvantaged and marginalised. Having said that, there are some specific issues that are very for vulnerable migrants. So we'll go on and talk about those, but I'm going to talk about trauma-informed care, which I know also Sarah mentioned in her slides. So if we could move on to the next slide. Is we talk a lot in the NHS rightly about trauma-informed care, but sometimes we don't really unpick what it is we're actually talking about so that we're all on the same page. So I've got a couple of slides here to talk about trauma, and then I'm going to talk a little bit more about abuse and neglect in this particular group. So in terms of trauma, it obviously affects how people function, not just mentally, but also physically. It affects your nervous system, it affects your sort of biological response to things, really overwhelms people's ability to cope. And this issue with trauma as well is that some people may appear absolutely fine to talk to, but actually it's one additional thing that could absolutely make somebody crumble. So it's really that approach, isn't it? To how you assess somebody, how you plan services for somebody, is that overwhelming feeling of vulnerability, helplessness and fear that really affects the relationships that people build and the trust that they have with us as professionals and organisations. So next slide, please. So to talk about, if we want people to be trauma informed in their practice, arguably they need to be working in trauma-informed organisations too. So at an organisational level, are we working in organisations that have that commitment to trauma-informed care and service? So are these services that create safe environments? We all know as service users ourselves, when you walk into somewhere, it's not just about your clinicians and your clinical care. It's the whole package, isn't it? The building when you walk in, the people who greet you, how you're treated, your first impressions. So do you feel safe? Is it the opposite to how you felt when you were traumatised? Do we screen for trauma? Do we meaningfully engage service users in organisational planning so that we can be really trauma informed? And also training staff. Do we train and support our staff, not just clinical staff, but everybody to be trauma informed? And we've got a link in there on the train bit, if you click that, to the free Learning for Health training on trauma. So it really is important that from sort of board to floor, we've got that trauma-informed approach to support our staff, to enable them to support service users, so that we don't create or replicate those traumatizing relationships and power imbalances that people may have experienced. So next slide, please. And trauma-informed care itself, it's not a therapy, it's not a specific intervention. It's a method of engagement, recognising those trauma symptoms, recognising trauma that people have been through, how that's sort of played out in their life, and really basically just shifting that perception from that medical model of what's wrong with you to really thinking from a perspective of actually what's happened to this person. And taking it from there. So really that approach that really stops that re-traumatization. So if in the next slide, please, we'll just look at some of those principles. So creating a safe space for people, as I said, that impression when you come in, do you feel safe? Is it somewhere with a window that's not got any bars on it? Is there a plant in the room? Is it well lit? Is it somewhere that is not cluttered or dirty? Do people feel valued and safe there? That transparency as well, having spent a long time working in the prison service, I know how important it is to be really honest and transparent as a health professional. So you've got to honour your promises. If you're going to say you're going to do something, you've got to do it. And if you don't, you need to make sure that you engage with the person to explain to them why it's not happened and why something's not happening. And choice, people who've been through these kinds of traumas that vulnerable migrants have often been through have had very little choice, and choice is taken away from you by the system itself once you arrive in this country. So there's something there about even small choices. Would you like a glass of water? Would you like a tea or a coffee? Where would you like to sit? Even small things really support dignity and respect and choice. And I'm not going to read through every single thing here, but I would say as well is we are very keen and interested to know what's happened to people, but there are limits to that, aren't there? And resisting the urge to try and get everything all at once. Go at that person's pace and respect what they want to say at the time. Build that relationship and trust. It sometimes takes time. And do read notes really thoroughly. Make sure we've got record systems that give time for people to read notes, because one of the most re-traumatizing things for people, citizen people and vulnerable migrants, is where you have to keep repeating your story and repeating things for assessments because people haven't had the time and space to look at the notes and get the records that they need. So moving on. So just to go back also to our amazing colleague who spoke about the Illegal Migration Act, is to call out the elephant in the room a little bit before I talk about the abuse and neglect, is we have some brilliant legislation, really visionary and aspirational stuff in this country that supports the work we do with vulnerable people. So we got, I'm not going to read them all out, but particularly the Modern Slavery Act, and a lot of the legislation that supports safeguarding and supports the health and care and support. But there is a tension, and we've always arguably worked with a tension around different policy and legislation. And the Illegal Migration Act and the last year's passage of the Nationality and Borders Act are an example of those policy tensions that we work within. So I think it's to acknowledge them and to say we don't know what the full extent of those is going to be yet. We suspect, we've seen some initial data of a fall in positive reasonable grounds decisions for victims of slavery and trafficking under the Nationality and Borders Act. We've seen that in the first quarter of that. And we are very concerned that in the Illegal Migration Act, people will disappear because of fear, and that they will go straight into the arms, frankly, of organised crime, slavery and trafficking, and they may surface for healthcare. So I think it's recognising those policy tensions, but actually as health professionals and strategic leaders, what we can do is ensure that our workforce is supported and trained so that when they do encounter somebody in these situations, they're able to respond and we're able to support them to do that. And we collect data and evidence to make the case for the impact of this on people's health and welfare. Next slide, please. So cumulative harm, I think we've also talked about that a little bit in some of the previous presentations. And just to acknowledge very briefly here, vulnerability, previous abuse, sadly, creates vulnerability to further abuse, and the research bears that out. So where we've got people who have fled things like conditions linked to poverty, political and economic instability, but not just war, but also climate change. We see a lot of instability for climate change, poor health, people who've got what we call protected characteristics, who've been persecuted for those in their own countries. And we see those vulnerabilities in people that they've suffered these cumulative harms that continue when people arrive in this country. So moving on, please. So the pre-migration experience, I think we've talked about it in some of the other presentations, but it is people of high risk and high levels of experience of exploitation, slavery and trafficking for adults and children across the lifespan. And that includes things like forced marriage, female genital mutilation, people with learning and physical disabilities, and many people who've suffered sexual harm. So sexual assaults and rapes, and that's men, women and children. It doesn't discriminate in terms of gender, unfortunately. It does affect everybody. It's not just women, although we do see predominantly women as victim survivors. High levels of domestic violence, and people who've either lost family members, they've disappeared or they've been killed, and people who have experienced or witnessed state torture and persecution. So moving on to the post-migration experience, it's hardly surprising that people really struggle to trust anybody from government organisations, anybody from any kind of state agency. People who are really isolated. There's a lack of meaningful activity in the hotels and the other accommodation, and I know people are taking steps to try and address that in some really great ways and creative ways, but there are massive risks to safeguarding in terms of exploitation, the risk of re-trafficking once people arrive in this country. Sometimes it's very quick for organised crime and abusers to know where the accommodation is for people who are vulnerable migrants, and to target that straight away in terms of re-trafficking those people, sexually exploiting them, or into criminal exploitation. So there are intrinsic and systemic barriers then for people to access care and support. And we also see a lot of concerns in the accommodation around either children who are in the adult accommodation who haven't been identified as children, where we see the age disputes, or conversely, adults posing as children who've been inappropriately placed in children's accommodation as well. And we briefly talked today about the impact of the High Court ruling on unaccompanied children. We don't have time today to go into detail around that, but we are taking steps nationally to escalate some of the legislative changes in statutory guidance we feel needs to happen to look after children who are subject to the National Transfer Scheme, because their needs are different to citizen looked after children, although their rights are the same. So if we can move on. We've got a lot of maternity issues as well, and people who are pregnant when they arrive or become pregnant, they've had little or no access to maternity care, antenatal care, and they also may be pregnancies that are a result of rape or and sexual violence. They are extremely vulnerable before they give birth and after to being enslaved and trafficked. And we see a lot of problems around access to things like interpreters, adequate nutrition for people when they're pregnant, safe sleeping arrangements in accommodation once babies are born, and a lot of concern about things like domestic abuse and sexual violence that happens while people are here in the accommodation. And actually a lot of concerns particularly from these women around any fear of disclosure affecting their asylum claim and their legal status. And obviously we're going to see an exacerbation of that arguably in the new legislation. But we also see some issues there around things like transport to appointments, registering the births and arranging appointments, things like that. And again, it's going back to that inclusion health piece, that this isn't just vulnerable migrants, this is going to be other inclusion health groups that encounter these sorts of issues. So maternity is a key issue. And moving on to children as well, is what we see with our children who are not unaccompanied. They're here with families. We still have concerns about kinship care and actually who is with, are they family, who is with family who may be just here with people that they've travelled with. It's very difficult to ascertain who is actually here with family and who's unaccompanied. And what we see in temporary accommodation for citizen families, as well as the accommodation for vulnerable migrants, is that safe space for children to play and be happy and to develop normally, to access to safe places to play, to have that normal development. And we know that those children are really at risk of safeguarding issues, either from the people who they're accommodated with or from people outside. That contextual safeguarding piece about people who are organised crime, criminal exploitation, sexual exploitation. And in terms of our unaccompanied children, they have all of that, and they have all the issues that our citizen looked after children have to contend with. But on top of that, they have that fear and uncertainty about their legal status and what's going to happen to them. A lot of our unaccompanied children are male. A lot of them are 16 plus, so we know they're going to become care leavers really quickly. So they're going to have those additional disadvantages that we know already are suffered by care leavers already in the system. So they are extremely vulnerable. Leaving care, they are extremely vulnerable while they're in care, in terms of going missing, in terms of exploitation and trafficking. And with our citizen looked after children, we tend to get reams of history about these children. They tend to have been known to services for quite some time, and we get a lot of history. With our unaccompanied children, they're coming to us completely cold. We don't have any history, and it is very difficult to build that trust. And even if we build the trust, some of those children won't know their own histories. So they really need that trauma-informed approach for us to build those relationships, to do health assessments on those children. So moving on. So I'm going to conclude now in terms of the so what part, I guess, is the big takeaway from all of this for today that I would like is to be really clear that safeguarding local statutory procedures apply to this group the same way as they apply to any other group. So if you are concerned about an adult child or an unborn child, you follow your local child or adult safeguarding procedures. Don't assume other people are going to make those referrals. And even if you know that someone else has made a referral, it doesn't stop you making one as a professional. The more referrals adult social and children's social care get, sometimes the better in terms of piecing together the concern and the risk. Be professionally curious, but do seek advice from your local safeguarding professional. Your designated nurses and your named safeguarding professionals and providers are an absolute source of knowledge and support and expertise, and they can really help you with the partnerships as well, because this is a real partnership response that's required to support vulnerable migrants. So I'm going to pause there and see if there's any questions. I know I'm standing in between you and the break, so possibly not, but any particular concerns or questions about safeguarding with this incredibly vulnerable group?
Okay, just content 2, so we will restart, I think, so that we get back on track. And I'd like to welcome Chloe and Ilana. Apologies if I've pronounced that incorrectly. We're going to talk to us a bit about health advocacy.
Hi everyone, it's just me today. My name's Alana. I am one of the final year medical students at Oxford University, and I usually talk about this work with my co-pilot Chloe, but she is on the Camino today in Portugal. So I think she's listening but might not be able to kind of dial in, so I'll take it over myself. So as everyone said so far, the landscape for asylum seeker healthcare is constantly changing, and there's a lot of difficulties. I was going to talk to you today about the particular kind of local context in Oxford and the Oxford Refugee Health Initiative, which is an organisation that brings together medical students, senior and junior clinicians and researchers to support the health and psychosocial needs of the newly arrived asylum seekers in Oxford. So I'm talking mainly about the kind of local context and how things have changed, a kind of chronology, and I'll hope to touch on some examples of some of the work that's been done and hopefully inspire some other people in other contexts to kind of continue this work. And yeah, just tell you a bit about what's been done, and then I'll talk a little bit about Oxford as a city of sanctuary. So a little bit about the history of the organisation. In 2015, quite a few Syrian families moved to Oxford, and there was a group of clinicians who kind of recognised a kind of vulnerable population in that sense, and they kind of organised a pilot project where medical students could be paired with Syrian families and act as kind of NHS advocates and going to GP appointments, ensuring they knew where they were, when to go, able to take longer histories with them and make sure that appropriate interpretation was being used where the pharmacy was, things like that. And, that went well, but then the pandemic hit and the project kind of died down. But then in November of 2021, the situation changed, and 80 unaccompanied minors came and sought asylum in Oxford, and it was quite sudden. And so Chloe and I kind of helped to restart the project and help in any way that we could. And at that time, because there were 80 kind of unaccompanied minors who were being very well taken care of by social care. However, social care was very stretched and couldn't focus as much on social integration. So in that kind of first iteration in 2021, a group of medical students who were well placed for this because of, DBS checks and safeguarding training and communication skills and cultural competency being taught at medical school, social care were happy for us to intervene quite quickly. And while there were other organizations around, the kind of volunteer training and DBS checks, and that would mean that the waiting list for, important stuff, just, we did a Saturday Welcome Club where we had regular kind of meetings with everybody and showed them different parts of the city, went on walks, did arts, did music, museums, things like that. And then alongside that, did a lot of mentorship work. So people who had increased kind of need by, seen to have increased need by social care were kind of referred to us, and two medical students who would be supervised by a clinician could act as their mentors. And again, we didn't invent any mentorship program, but medical students were really well placed for this work simply because of that kind of safety stuff, some DBS checks. Sorry, I missed that. I think someone was unmuted. So yeah, the mentorship branch is still in action, that kind of third branch of the work that we're doing, but the situation dramatically changed, as it's going to continue to. But in 2022, over 200 people came to Oxford overnight with very little notice when the Manston Detention Centre was shut down after public scrutiny. So we were had, I think, 2 days notice that over 200 people were going to be sent to a hotel in Oxford. And it was clear that there was great unmet health need, both from the journeys there and caused by being in detention centres. And, you know, there were a couple of GP practices who were meant to take on these asylum seekers that were coming, but it was going to be quite a big project. So we kind of facilitated urgent GP registration and initial health assessments. So that's kind of like one prong of the work with the newly arrived refugees and newly arrived asylum seekers, sorry, is that medical students with supporting clinicians and with the GP practices can help register that huge number of people in a hotel. And the medical students are also, you know, well placed when they're further on in their clinical years to do some triaging. So one example that kind of highlights what it was like on the ground, it was quite chaotic on the ground, as you can imagine. A lot of people hadn't seen doctors in a long time, and everyone was wanting to see the doctors. So, you know, we were registering them with a GP, but at the same time looking for any red flags, anybody that needed to be seen that day or soon. And, you know, we kind of, I ended up taking a history from somebody who looked particularly unwell. And, you know, he showed me a picture of, you know, tapeworms in his stool, and he was, you know, not doing very well. So kind of found him a slot with the doctor that we were with that day, who then got him an appointment with the infectious diseases team to be seen quite urgently. And another student, actually, no, Chloe, who was also on the call, Chloe ended up accompanying him to the appointment with, you know, so many barriers because you have to get a taxi from the Home Office. So that didn't work. They sent them to the wrong hospital. So another taxi to the right hospital. And then finding where the appointment was difficult. And then making sure that language line was used and interpretation was used. And she was, you know, she kind of reflects a lot on the, yeah, I mean, how lucky it was that she was there, because it really was a difficult journey to seek healthcare. But that's kind of one example of what that looked like on the ground. So kind of registering over 200 people, but at the same time trying to single out any urgent cases. The situation, again, is different now. There's over 800 people in Oxford with an additional 400 who are meant to be coming. But there's 5 hotels that are contracted by the Home Office to temporarily house these asylum seekers. And as has been said before, these hotels are not fit for purpose, and local services are stretched. So ORHI is mainly responding to unmet health need. There's a lot of other charities in Oxford who are responding to, you know, other needs like schooling, education, and kind of group therapies and things. But we have kind of 2 prongs. We have the health registration in clinics. So students kind of go through the lists of people who are registered with GPs and do a more in-depth health assessment screening for vaccinations, any symptoms of, you know, infectious diseases that are, you know, of increased risk in that group, such as TB, a kind of quick mental health screen, and they kind of can facilitate that for the GP just to make sure that they're on top of the health needs of this group. But then another prong of that is health promotion. So we've gone into these hotels for presentations on how to access care, what you're entitled to, which is free prescriptions as an asylum seeker, how you can ask for interpretation in language line, and then just working with them to see what they want to know about. So we've done a few that are led by them. So examples of that would be they wanted to learn about common pediatric conditions and who to go see, which numbers to call, what websites they can use. And we kind of refer them to websites that are both in other languages and also have audio forms, because many of them can't read. So trying to be kind of responsible and understanding what people want out of it as well. Always changing what we do based on the local need. So yeah, so there's a few. So the student development thing I'll talk about, and then I'll talk about one example of another kind of prong of the work that we've done. So in terms of the student development, obviously contributing to this work can allow medical students to feel inspired and useful, and in a climate where kind of being a medical student in the hospital is not great at the moment, I must say, with the kind of difficulties on the ground by, you know, people feeling without hope at the moment. So this is, you know, we've had a lot of people reflect and say that this has really kind of inspired them, but also at the same time, we're trying to create, you know, socially accountable medical doctors and people who will, you know, this work will enhance their personal and professional development. And we do that with educational talks, regular kind of reflective spaces and supervision, and, you know, active involvement in the kind of developing the social determinants of health curriculum, as this is essentially social determinants of health on the ground. And then just the kind of, I'll give a last example of some of the work that we did to show you, I mean, it kind of shows you how ad hoc everything is, but also how having this organization by a group of you know, people who have time, medical students have time and energy, and knowledge as well. So there were 2 scabies outbreaks in the hotels, and they were placed on lockdown. And, you know, they had the whole kind of public health risk assessment. However, there was no movement after that. And we kind of had to come together and coordinate a response with clinicians. We had a local public health nurse who assisted as well. But, you know, this was a scabies outbreak, one in particular in a hotel with over 200 people and 2 washing machines and over 20 languages. And you have to do the treatment all at the same time. You have to repeat the treatment. There's a lot of cultural difficulties with you know, asking someone to have a treatment for something that they may or may not have, but you need to do it kind of altruistically, and also because you might get it later if you don't treat yourself as well. But also kind of cultural difficulties with, you know, putting the treatment all over the body, and how that is communicated in different languages. And one person, you know, the way that we ended up having this successful intervention was having asylum seekers who from another hotel who were fluent in English and another language help us with this and provide, you know, a perspective that isn't, you know, an agent of the state telling you to do something. And we also worked with people that were kind of identified as being quite important to a specific sub-community. So one person that came to mind was a brilliant young person who spoke perfect English and Kurdish Sorani, and she was 14, and she was obviously a very valued member of her community, and she really helped get everyone on board. And that was quite a large population in the hotel. And she was kind of instrumental in helping us with the intervention. And after spending the morning with her, you know, she confided that she was really struggling because the hotel had asked her to, in the middle of the night, had asked her to come and interpret and translate for the hotel staff when a member of her community had attempted suicide. And this, you know, this kind of example was really important for me in realizing that while everyone has come to the UK with hugely traumatic background, as Victoria Gray was saying before, the asylum seeking process in the UK is traumatic in itself, and it's local experiences that are re-traumatizing and causing further harm. So it's our responsibility as the local people to respond to that appropriately. So the last, I think I'm okay. The last little bit, I'll just talk about how Oxford is a city of sanctuary, and that kind of leads me on quite well to talking about local responsibility to making sure that seeking asylum here is not fraught with violence and hostility and unwelcoming messages, because at the moment the political landscape is just that. The aim of the movement is to provide a network of local organizations and to, you know, have a large statement of solidarity. So City of Sanctuary started in Sheffield in 2005, and Oxford became a City of Sanctuary 3 years after that in 2008. And what that means is, you know, 1, that kind of statement of solidarity. 2, it means that the voices of those that are going through this process is amplified by the people who live there and who are part of the local community. And it also means, you know, there's a platform where lots of different groups who are, you know, interested and have different expertises can come together because they have a similar mission. So it's just, you know, a way to collaborate. And the University of Oxford actually became a University of Sanctuary last year, and there was a town hall assembly with everybody, all the charities, all the organizations, and many of the asylum seekers that are, you know, volunteering as well. And it was an amazing experience to link everyone up and we can now refer people to some of the music groups we didn't know about, or there's a museum project where some of the asylum seekers are cataloging items from their own country that, you know, people in the UK don't know about. So, you know, that I think, yeah, I'm not sure what else to say about the City of Sanctuary, but just that it's a great movement with lots of resources for schools, libraries, healthcare. And yeah, you can take the pledge as an organization, or you can, you know, volunteer within the city itself as well. Thank you very much.
That's fantastic, Alana. Thank you. Really exciting stuff. And from a Portsmouth perspective, I'll be in touch, because I think we really value some hearing more about some of the learning from that, because well, personally, from our council perspective, we have a lot of junior doctors that come and work with us, and I think there's an opportunity with the universities both in Southampton and Portsmouth to perhaps capitalise on some of our medical students and galvanise in a similar way. And yeah, really, really helpful to hear what you've been doing, and some fantastic stuff. Thank you. I've just been thinking, as Ilana's been talking, and obviously listening to Vicky earlier, and it's just reminded me about we all obviously have our own experiences of trauma throughout our lives, and it's just a reminder to, if we are, certainly this afternoon we're going to be hearing about more practical examples and stuff. So if people are hearing things that may trigger memories and things, just to be kind of to yourselves, and remember that there is support available, and should you need it, and if you do need to take a break, please do so. With that, we will move on to Lena, who's going to talk to us about developing inclusive healthcare. Welcome, Lena.
Hi, thank you very much. Lovely. I'm just waiting for the slides to appear. They have been sent in. So whilst I'm waiting for the slides, just to introduce myself, I'm from Alliance for Better Care, the GP Federation. My name is Lena, and I'm head of the Refugee and Asylum Seeker Service. Thank you so much to the person who put the slides up. So it's only 20 minutes, and what I would say is won't be able to cover everything in depth, and obviously the emphasis is on sustainable health pathways, but please do visit our website. We've got more information that we're just putting up currently. So we initially were a little, you know, we've been doing this for 18 months to 2 years, a little bit cautious initially what information we shared on a public website, but actually there's so many people involved in this, and it's such a large piece of work, and we very much consider refugees and asylum seekers as part of our community, so we're beginning to add more information now. So just about as we are a GP federation, so we have 47 member practices, we work across 12 primary care networks, so we have the advantage of knowing our primary care colleagues well, and we support them to transform how healthcare is managed within the community. And as I said, we consider refugees and asylum seekers, some who won't be with us for very long, but very much part of our community. And as a federation, we have part of our role is to connect areas of primary care to other parts of the system, and they may already have those connections, but strengthen them and support them in that, and working with GPs and the whole primary care teams. So we're sort of like a bridge between our practices and the wider healthcare network. So when a couple of years ago, we initially were working with quarantine hotels is how we started. So we had British people coming into hotels from a holiday, and just, you know, having to stay there during COVID. And overnight, with very little preparation and no time to do any sort of strategic background work, it turned into a large hotel of about 700 to 800 people accommodating Afghans. And we had to adapt our service at pace. Okay, next slide, please. So yes, we think that we're the only GP federation in the Southeast to have a dedicated refugee and asylum seeker support team. As you can see, we've been able to respond to a very difficult humanitarian challenging issue, but and we're proud of the work that we've done, but I have to absolutely say we can't do any of this on our own. Personally, it's probably been the project that I've been on that's had the most collaboration I've seen in health and social care. And it's been start of a learning journey. We absolutely, and I'm going to shout out right from the very start, needed our voluntary sector colleagues and council colleagues. And I think because it started in a crisis with suddenly being told there's 800 people there, barriers were down. There was immense need and no preparation, and so we worked together very cohesively in the beginning, and that actually paved the way. So there's been lots of difficulties, but starting in a crisis in some ways paved the way for future work. But we've definitely had to go back. It started in the crisis and put some of that sort of planning that we would have done beforehand back into the service as we've gone. So serving our wider community. If you could just go to the next slide, please. Right. So as I said, started in the crisis, and we really had to, that photo reminds me, actually, we sort of went in into the quarantine hotels with a mixture of colleagues, doctors and GPs, trying to identify what are the absolute priorities for people who've arrived here with unknown health needs, not able to access the system. What's the bridge? What's the role that we're going to play? We have people, we now work across 20 hotels, and we have people who, some were with us for very short periods, just a couple of nights, and come directly from Manston. Most of the people that arrive come on small boat crossings, and we have to make a very quick assessment what their urgent healthcare needs, whether they're diabetics who've arrived without medicine, whether they've lost their telephone, whether they're pregnant, etc., and then build those pathways out. And we at the same time, that early recognition that a prescription for somebody that arrives in a crisis is going to be much broader than just a clinical response. So as we went from room to room, we realized early on, so a prescription might be pain relief and antibiotics, but it might also be a warm coat and a pair of shoes. And I've got early memories of, seeing small children, some without shoes, and we didn't have anything to measure their feet, and actually literally drawing around their feet on a piece of paper and saying we need shoes this size. So agility was absolutely key. Next slide, please. So we now have a population of about 3,000 people. The data, at best, anybody working this will know that data is an ongoing challenge. So we never know exactly how many people, because we don't have data in real time. Quite often we know that a hotel has been stood up after it's been stood up. And when I think 3,000 people, that's beginning to be the size of a small GP practice list. So it's quite a population, and they're across 20 hotels, and that covers Sussex and also East Surrey. Just to explain, we work across the hotels in Sussex, and Sussex is a big county. One of the things that we have done is subcontract to one area in Sussex, because we're really conscious that those GPs and those primary care teams will be best placed to know their local pathways. So we really have brought them into the service, shared all our learning, and they have access to all of our systems and training, etc., very much part of our team, but making sure that we harness that local knowledge and the voluntary sector that they bring with them. So certain challenges in terms of working across Surrey and Sussex. I know I've got a colleague on this call who I work closely with, Lisa, an inclusion health team, and we have had to navigate, one situation where we've got a hotel car park in one county and the hotel building in another. And that was an industry in itself as to how many emails went backwards and forwards trying to work out who should be responsive. So we've tried to develop an integrated response. Can't go into all of this in depth because of the time, but from people's initial arrival, actually taking them all the way up to integration, assimilation into, obviously they become registered with a local GP practice, but those next steps, living in the community. Of course, some people are placed outside, but some people will remain with us for a couple of years, or indeed, continue their life here. So we've tried to sort of take that pathway of, you're here now, and this is the most pressing healthcare need, but actually going forwards, we know that long-term living in a hotel is not conducive to good health. What other things can we put in place to broaden out that offer, work with our partners, and so that clinicians, when they see people in hotels who, they will respond and assess to those urgent needs, but equally, if it's boredom, if it's the need for meaningful activity, what can we offer? So those clinicians can actually say, by the way, there is football every Wednesday, there is cricket there's a women's group, etc., etc. And that's been a really expansive piece of work. Thank you. So our core offer, so we have a dedicated refugee asylum seeker service team. We provide clinical assistance as well as practical support to people arriving in the UK. In Sussex, we have a medical director, we have a lead nurse. Now, we didn't have all of this to start off with. We have we have a designated clinical lead doctor, and then we have nurses and paramedics and GPs. So every day they will ring around the hotels and try to identify what are the health needs and then plan their workload and go out. So they will see patients remotely. Obviously, everything is done through a translator, and they will also go out and see patients in the hotels. We've learned quite often that actually being present in the hotels is when we find out about further needs. So it won't always come through that initial contact with the hotel. And we have really had to work hard with our relationships with the hoteliers to get trust and confidence on both sides. And we also get a lot of calls from the voluntary sector who will say, I've seen this person, a bit worried about them, etc., etc. It's not perfect. We always worry about the people that we're not seeing, which is why we know that with this population, of face-to-face presence is really needed. You'll see that we've also got 2 social prescribers and a care coordinator. So we were very fortunate to be funded for a pilot project in personalised care, so that we can be responsive. They've got quite a narrow referral criteria around low-level mental health, around meaningful activities and being connected to community assets. But they can work hand in hand with the clinicians and try to identify people and connect them to either projects that are running, or actually if there isn't a project up and running, who do we need to talk to and who can we collaborate with to get things up and running. So thank you. So as I said, the majority of our patients do come through small boats. We've been down to Manston, trying to understand that pathway. Was very illuminating to actually understand what health provision happens there in that early stages. And obviously many people, what our learning has been is that people often don't disclose their health issues until some time after they've been in the hotel. We also had a request for an urgent response to a flight that came from Khartoum. I think it was probably about April, where a flight was supposed to come into Stansted and relocated to Gatwick. So we had an hour and a half to go down there, asked by the council, because we now had a good relationship. And we then had to put a makeshift clinic within an airport lounge and try and see those people and pull out, who had arrived without urgent medication, who was pregnant, which children weren't well, and adapt. And I think we've learned over 18 months to set up in non-clinical environments and make them as good as they can be. So we now, obviously, we risk assessed our hotels, we look for the space, and we've worked with the hotels to try and get that confidential space. We are now doing dressings and burns dressings, and of course the environment isn't ideal. So we have a lot of kit to try and adapt any environment. It's not perfect. Hotels are all different. Some are very remote. There's been a lot of learning behind the scenes to try and, do we use screens? What's the best way of doing this? And within 24 hours of arriving at a hotel, we try to send a team out who will eyeball those people really in the first instance, sort of a quick surveillance, who really has an acute need, is there anybody that needs to go directly to hospital, etc. We're very lucky that we have an inclusion midwife who has a presence, so we've got a very strong maternity pathway, and then we set about adding them to clinical systems. All our work is done with interpreters, and then we set up our diphtheria screening clinics, and a lot more will emerge the more presence we have in the hotel as people start to hopefully build trust. So we then obviously gain consent to the diphtheria pathway, prescribing antibiotics and vaccines, etc. And at the same time, we're setting about addressing urgent health needs. So then we support those refugees and asylum seekers to register in local GP practices. And that's where we also support the practice. So we, on a daily basis, are trying to pick up the urgent primary care stuff so that we avoid people going to ED, where a GP could respond to that, and also support primary care so there's not that pressure on the 8 o'clock, where we know that particularly people who don't speak English, who don't have digital access, they're going to struggle to get appointments. So we're working in that space. No, okay, so it's, as I said, our service complements primary care provision. It's a wraparound service. We're conscious that once people are registered and are able to make their way to practice, that's part of their normal journey with those management of long-term conditions. And we do meet with GPs regularly in the practices, sort of picking up patterns and what else can we help with? Where else can we evolve our service? So, for example, we now hold women's clinics in the hotels as an add-on. It's 7 days a week, 12 hours a day across the hotels. And it's, you know, we've certainly been involved where we keep an eye on what the levels of conveyances to hospital are. You know, sometimes it could be a couple of people calling ambulances, quite a desperate state, and that's where we would try to get in there and work with them to reduce that presentation at ED, which isn't ideal for anybody if it's not needed, or to facilitate people going to ED if it is. So we have the telephone triage and assessment, access to video calls, and obviously working closely with pharmacy colleagues, actually, because you know, even once a prescription has been given, refugees and asylum seekers may not be able to access it. So we obviously work with pharmacies that can deliver, and that produces quite a lot of work in and of itself when we're putting in bulk orders for particular medications, for example, as the previous person referenced, scabies. So just making sure that we've got what we need. We also carry quite a lot of over-the-counter stuff for people, because mindful that if they're living on the Aspen card, they won't be able to afford things like, you know, Calpol, ibuprofen for children, etc. Thank you. So this outlines the clinical services. So there's the pathway development. So the main pathways that you would expect around maternity, around mental health. Mental health, really prevalent. Some of that can be addressed locally, you know, with the GP support and connecting people to activities, but obviously it also needs there's a triage and an onward referral. Pediatrics, all the pathways, you know, we see dermatology, and now we have seen an increase in people coming with burns. So nurses will go and address those burns, and we'll also be looking at how can we upskill our workforce if we see a new pattern, you know, what sort of training can we put in place. We've got the diphtheria clinics. We're also cited on outbreaks. So we did have a hotel with a few active cases of TB. So working with respiratory colleagues in the hospital, and actually we had to go out and do work up a project to do chest x-rays on the site of that particular hotel and manage. Once you've been working in that hotel for a while and built those relationships, it's so much easier to continue and do the public health messaging, etc. So lead the emergency responses. We're looking to develop MSK clinics, so musculoskeletal with physios. TB clinics are part of our core offer, and also translating national guidance into local information. So, for example, diphtheria, when that came down, how are we going to operationalise that and translate that quickly into something that we can offer locally? Vaccines, and as I mentioned, women's health, and we're now being alerted to the fact that measles is been cases of measles. So, what could we offer? So, conscious as well, working very much with primary care, who will also offer measles vaccinations, MMR. So what's the best way of doing it? Thank you. So personalised care. So this is where we've got 2 social prescribers and a care coordinator. This is a pilot project and it's relatively new, so we're still learning what's the best way of doing this. We're really keen to recruit people with lived experience and have done that within our service. So we have recruited people who are permitted to work but have a refugee asylum seeker status, because we recognise having refugees and asylum seekers championing the work, that lived experience is so key for us getting it right. We have a care coordinator, and all sorts of work can be done around making sure people have got access to free prescriptions, making sure that dentistry is a big issue. We have worked with a mobile dentistry, Dentaid, but how can we connect people to those very limited precious dental appointments, people who've lost glasses on their way, visual aids, making sure that we've got good relationships with the wider primary care opticians, for example. We also have a project, we talk about something that's sustainable, is, you know, we have a presence 12 hours a day, but actually hoteliers are with these people 24 hours a day, and actually refugees themselves and asylum seekers, if we can champion people and put them on mental health first aid training, it just bolsters that offer. So we've now got a project to recruit refugees and asylum seekers who would like to take part in mental health first aid training. So they can also be additional eyes and ears, and identify people. That's always our concern, is the people that come forward we'll see, but what about the people we're missing? And that's where it's really important for us to have those relationships with hotel staff, recognizing that they may not have had additional training. So how can we support them to identify the right people who should be coming to our attention? And that's something about that sustainability, particularly in a fast moving, high risk population. So yes, as I said, it's a pilot project, so we're still waiting. We're gathering data and looking forward to reporting back and seeing what patterns and where else can we add value. If we could just go to the next slide, please. Conscious time is nearly up. Yes, this is a obligation of every person born in a safe room to open the door when someone in danger knocks. I'm sure you've seen that before, but it's quite a moving, you know, it's tugs on the heartstrings a bit, but you know, we would try to live to these values and very much include people in the community. Next slide, please. Yes, community engagement is huge, and it's becoming even bigger. And I think we really recognise that actually clinical part is a really important part, and we are a health partner. That said, we see a big connection with the wider determinants of health, and if we can help people by you know, support them with their well-being by the things that are offered here. We do work, we meet regularly with 25 voluntary sector organisations. You know, we hold that space, and the traffic that goes backwards and forwards on a daily basis, it's additional eyes and ears, but actually those collaborative bids, so powerful. Now starting up community kitchens, sort of shout out to the people that trailblazed that in Surrey, and now we're going to try and emulate that, because food is a big issue for people. Trying to put on, we have done lots of trips using volunteers, and in fact it's been something as an organisation that's really harnessed our staff, who many of whom have volunteered, done you know, taken part in extra groups, etc. We have a weekly gardening club, because we have a little garden where our office is, and we're within walking distance of 3 hotels, and we thought, why not? We didn't really think about who had the gardening expertise, so then we had to make an emergency call to Wakehurst Place, which is the Royal Horticultural Society, and say, can you help us out? But what a great partnership that was, because they have now invited refugees and asylum seekers. We put on a trip to visit Wakehurst Place, and there may be an opportunity for further volunteering. And what we're really trying to think about is getting people employment ready for their next steps, because most people tell us they want to work. Thank you. And you know, we're proud to support as an organisation. We've got a few key charities that, you know, you can see there, Sussex Aid for Refugees, who are working hand in glove with us to make sure that they're responsive. When sadly, we've got quite a lot of women who've reported sexual assault. What are the support that we can put in, you know, clothing, all the sanitary products, etc., toiletries? How can we work to make it a little less difficult for people? And we couldn't do any of this without our key voluntary sector partners. So much more information on our website. I'm not sure if that's our last slide. It might be. Yes, please do visit our website. It's been really interesting just hearing the previous project from Oxford. We connected with them. There seems to be so many valuable partners working in this space, and the more we join up, the better. Thank you.
Wow, thank you, Lena. Truly inspirational, and I think we all want you in our patches. But a quick question from Robin in the chat. He's asked, may I, I'm not sure if you said it, but ask how the service is funded.
So it is commissioned through,
okay.
It is a commissioned health service. I would say all the other additional work, you know, so the clinical 12-hour day, 7 days a week has been commissioned. The other work is us just working in our geography with our voluntary sector partners. It takes an enormous amount of effort, but it's a real enhances that clinical offer. It speaks to our organisational values. And actually, once you've got such a collaborative group, you can tap into that group for other things like homelessness. And we're now seeing some of these people sadly fall into homelessness, but we've got that group set up. So we'll continue to work together.
That's fantastic. And the pilot, how long is the pilot for?
It's a year's pilot, and
Okay.
it's until the end of the financial year.
Fantastic. And are you evaluating it as part of?
Very much so. We've worked with I think they're called MyCall, meaningful measures, to get a particular outcome tool to collect that data, because recognition that actually asking refugees and asylum seekers questions, it needs to be quite gentle, and actually we wanted a tool that really reflected that. So we are collecting that data. It's been a lot of work actually getting that set up, but a really valuable project, and we really want to prove the case for it, because we know that personalised care is specialised but much needed.
Yeah, it's fantastic. Lots for people to take away, I think, from that and to learn from. Suzanne, have you got a quick question?
Yeah, just to, somebody was asking about the funding of the service. So yeah, this is funded by NHS Sussex, but just to say that it is funded at risk. We have not funded by NHSE to deliver this, and are doing so at quite significant risk to NHS Sussex, but understand and realise just how important this service is.
Brilliant. Thank you ever so much, Suzanne, for clarifying that. It's really helpful. Wonderful. I'm sure you will get lots of questions coming to you, Lena, after today. And
thank you very much.
I suspect I'll be one of them. Let's move on to Lindsay and Becca to talk about how we learn, collaborate and develop.
Thanks ever so much, Emma. That's great, and to follow on from Lena, you've really inspiring. So thank you. I'd like to introduce myself and my wonderful colleague Lindsay. I'm Becca Randall, and I'm representing Kent, Surrey and Sussex Academic Health Science Network, soon to be Health Innovation Network. And Lindsay here is representing Wessex, and we're also joined by colleagues from Oxfordshire too. And what we're going to do in the next 15 minutes is give you an overview, or stress the importance of our roles in supporting innovation, discovery, hearing the needs and the voice of not just practitioners and clinicians and those working with our migrant populations, but those with lived experiences themselves, and the importance of research across the South East. Funded by NHS England and funded by the Office of Life Science. So I'm going to hand over to Lindsay, and I'm going to take the reins, if that's okay.
Thank you very much, Becca, and it's a pleasure to be speaking to you all. I do feel that we're kind of a sort of a slight distance away from what happens on the ground, but what our aim is as AHSNs is to share, innovate, support, and make sure that we're linking all this work together across the UK. Just a really quick slide just to explain who we are and what we do and how we exist and how we work as an organisation. There's 15 different networks across different patches in the UK. Our fundamental aim is to benefit patients, the NHS and services, but to create health and care efficiencies. And recently, in the last year and a half, we've had a very specific remit to support health inequalities and inclusion health, and different AHSNs have tackled that in different ways, and we've had specific funding for some projects. But today Becca and I just want to talk a little bit about some of the other work that we've been doing to help people on the ground. Well, our other ability is to do that moving around and shifting and sharing best practice, which I think we do quite well. Next slide, please, Becca. So although this is a South East network meeting, I'm obviously work across Wessex, which includes the South East, but also includes Dorset. And I think Dorset has been in the news a lot for migrant health and for Bibby Stockholm and all the work that's gone on. So I can't kind of stand here and not mention that in this forum. But so there's been a lot of ask of us as AHSNs to come forward. And this is how we started off and think about developing this session as well, is to think about homelessness services, becoming more inclusion health services. Our local primary care networks across Isle of Wight and Dorset have had kind of a big ask when I think lots of people just said all of a sudden hotels are retransformed and migrant populations move in because that temporary combination is needed now. and actually people are mobilising and moving, and health services have to mobilise and move very, very quickly. And we've heard some really amazing, fantastic examples of that today. But there is, in some areas, that's been more challenging, and there's been not so much the capacity in the trained staff to be able to mobilise quickly. People have asked about how can we support in terms of innovation with multiple languages. And there is some innovations out there that can help with that as well. And some of the complex needs assessments in terms of physical and mental health, again, moving into that trauma-informed care that we've also heard about today. But I don't think not everyone is in the space that some of these great innovations and great work that we've heard about is at the moment. And the social infrastructure, which I think Lena was just touching on about the community infrastructure that supports people, isn't set up in all areas. So we wanted to start sharing some of that expertise. We wanted to start learning about what's worked well and why has it worked well, and be able to share that to our primary care colleagues, our homelessness colleagues, people working in inclusion health across the region. Next slide, please, Becca. So particularly in Hampshire and Isle of Wight, I also wanted to remind people that although we're kind of very much thought of as an organisation that's very academic and kind of puts in science and innovation, we are a network, and that's something that we do very well, that we're kind of heavily linked to the right people at the right time, and that we can link clinicians together to come together with a shared interest in a shared space, which offers that learning and development. And we've often, as HSN's, facilitated this piece of work. Next slide, please, Becca. So within Hampshire and Isle of Wight, one of the pieces of work that I've supported has been setting up a community of practice. It started with the local homelessness service that was thinking about how do we include people more, how do we become more inclusive, and linking them in with other kind of GPs. And lots of GPs and primary care networks had been working with migrant populations, asylum seekers, and mixed in with homelessness populations, but wanted to share what they were doing well and what worked well for them, and also to provide that network of support and to be able to talk to each other because of some of the complexities and some of the solutions that they'd found as well. The communities of practice can be really, really valuable. But it's not something that you set up and just run with and there's a clear agenda and it's spoken sessions. It's about people coming together with a shared agenda or a domain. They want to talk about the same subject, and that's how it kind of fosters those sort of social relationships, and then people start to bring more things to the table. So it's about knowing people and know you've got a safe space in a group, and it's built around that clear domain and then what your practice is, and then building that community. So it's been really, really valuable to help people just talk about their experiences from a clinical practice perspective. Next slide, please, Becca. And over to you, Becca.
Thanks, Lindsay. And I'm actually not steering the slides, but it's very kind to keep asking me to move the slides on.
Thank you.
I want to just share some of the work that we've been doing in Kent, Surrey and Sussex to give you a bit of a flavour. Very, very quickly, some of the work that we've done is linked into the discussions around community practice, but also around the research agenda. So here we can see an example of some of the mapping work that we did initially, looking at some of the data and some of the services across Kent, Surrey and Sussex. We were very much aware, and this was done a couple of years ago, so it is out of date as soon as it's published, of course, but at the time there was very little data around that was available. So we were able, through our postdocs, to develop some mapping, and this was shared with our commissioners and embedded within commissioning planners at the time. Some of the service specifications particularly around mental health and emotional wellbeing services for migrant populations, and through some of our with our public health colleagues around our joint strategic needs assessments. Next slide, please. So in terms of communities of practice, we developed we've got community of research practice. We run one across Kent, Surrey and Sussex. Anyone that's interested, please do contact me. This is around our academics and our stakeholders. We've very much focused initially around research, where we can share that research, build on research, build research capacity, make sure our academics are undertaking the research that's needed by you within the system. That's really important. And we're working with Kent County Council to develop a lived experience research group, particularly around unaccompanied asylum seekers. And we have a plethora of blogs and videos that we've been able to hear those voices and embed that within research and service provision. And I'm going to talk about the training in a minute. Next slide, please. So we held our first community of practice. We had about 90 people attending just over a year ago, and it was really important to bring together stakeholders, voluntary community sector, mental health trusts, academics, and of course lived experience, to share some of the research that was going on, some of the research findings, look at good practice, because one of the things we can do as AHSNs is horizon scan and look and see what's happening elsewhere across the country that has that evidence base, and hear from the lived experience. Now this slide's a bit of a busy one, but I just wanted to share that one of the key things that we did at this community of practice was identify some of the barriers. And I'm not going to read them all out, but just to echo on what's been said already today, the need around cultural diversity, providing services in different languages, not just relying on our interpreting and translation services, the ask around co-designing services with our migrant populations rather than just by professionals, the importance of intercultural competency training for the workforce, the importance of consistency of staffing, building relationships and working with the same person throughout, importance of advocacy, building on what's been said already. Networks, amazingly, that these community of practice brought networks together. So practitioners in different geographies, bringing them together to share practice, not having worked together before, helping with signposting, and asking around creativity and visual representations, not just word, and looking at more peer-to-peer support and social prescribing. It was really important that the signposting to informal and community support networks was lacking, and they people with lived experience in our workforce wanted more information on what was available locally because it was ever changing. Next slide, please. So one of the things we've been able to do is to get some funding through Health Education England for some intercultural training, competency training for providers. And this was identified within the community of practice. So we're really pleased that we'll be able to work with NAFSIAT, Intercultural Training and Therapy Centre based in London, to run some sessions. Who are they for? Anybody working with this population group. Housing, border force, our hotels were identified as a key stakeholder for training, schools, colleges, police, and please do, if you are interested or you work with an organisation that's interested across Kent and Surrey and Sussex, please do share your contact details with me. We are evaluating it, and we will be looking at developing a toolkit that can be shared further. Next slide, please. One of the other things that we do is through our applied research collaboration, is we fund research around a range of different priorities, but we're funding a number of PhD students and universities across Kent, Surrey and Sussex to do research in this area. I'm not going to read all of those out, but you can see it ranges, and this is just a selection of some of the research that we're looking at. Young migrant women, Ukrainian refugee communities, Greeks, our Afghan citizen resettlement scheme, looking at service evaluations and looking at academic research. The importance of our roles is to ensure that this research is not only undertaken based on need, but also applied or implemented into practice. And our contact details are at the end of the presentation, but again, if you're interested in accessing some of the findings of the research that we're funding, please do look us up. And close to the final slide, it's a privilege really to use one of these pieces of research as an example, and I know Patrick is on the call. Patrick is an amazing, fantastic PhD student who's done some brilliant work, particularly focusing on East Sussex, and I probably won't do it justice, Patrick, but please do reach out to Patrick if you'd like to know more. Some of the work he's been doing, funded through the ARC, has been looking at some of those barriers and barriers to bridges, particularly around our female migrant communities. And again, repeating quite a lot of what's been said today, issues around cultural language barriers, issues around information and access to mental health support and information in particular. And Patrick particularly calls out specific areas around mental health, menopause, neurodiversity as some of those key areas. Intersectionality barriers we've talked about today, stigma being the key barrier, the biggest barrier that's been identified. And the key area I just highlight at the bottom here is around GPs, and the research has identified that actually a lot of female migrant community groups accessing GPs around physical issues, but an opportunity really to look at accessing GPs around some of our mental health issues at the same time. And finally, again, we're just reinforcing what's been said before about the awareness of and availability of informal support systems. Brilliant to hear about the work around the social prescribing earlier and the kind of community focused groups, but really accessing the importance of accessing that information, sharing that on as practitioners. So, final slide. That's us, the 3 AHSNs, soon to become Health Innovation Networks. Do reach out to us. Reach out to us if you're interested in any of the research. Reach out to us if you're interested in any of the communities of practice that we're focusing around our migrant health and wellbeing networks that we run. We're more than happy to get back and link you in. Thank you, Emma.
That's fantastic. Thank you both. Some fantastic work going on there, and I know we've valued down in the Wessex region the work that's been happening with Lucy and colleagues. So thank you for that. We've got about a minute if there's anything burning that anybody wants to ask at this stage. But if not, we'll capture anything that's in the chat. Go on, Lisa, you got a quick minute to ask.
Very quick. I just wanted to ask Patrick, I'm fascinated and it's so interesting what you're describing. I'm desperate to get involved in this. But did he have any barrier? Did he face any barriers in his PhD research as a man looking at the women's issues, given all of the vulnerabilities we've talked about? I'd be really fascinated to hear from him if that's possible.
Patrick.
Yeah, sure. That's a very interesting question. I've had quite a lot of barriers, but the biggest barriers were actually my fellow academics that did not believe in me. But the biggest asset, I would say, was that the female migrants were more than willing to talk to me. And for a lot of them, I was the first person ever to be actually interested in what their experiences were. So I would say, yeah, academia has been the biggest barrier, I would say. Sorry about that.
Thank you. You're very brave. Well done. It's fabulous work. Thank you.
Brilliant. Great question. You've all frozen, so hopefully you can still hear me. So Karen has put in the links for the next bit in the chat for us again. So just a reminder, there are 3 parallel sessions now, but I can only see 2 links at the moment. So if you would like to take the opportunity to join one of those sessions, you'll go on hold in this main room. So if you just click the link and join that meeting, and then when that session ends at 1:15, you can just resume the call for the main room and join us back in this room. Okay, so there's a maternity session, a health protection session, and an oral dental session, which I can't see.
So Sarah, you will need to click on the dental one to go into that room. and I'll come and join you shortly. So can you see in the chat?
Welcome back, everybody. I hope you had a good session, and we will kick off back with our last kind of general speaker with Kathy and Kathy.
Thank you, and hi everyone. So we're going to do a bit of a double act, Kathy and I. So I work for the Office of Health Improvement and Disparities in Yorkshire and Humber, work closely with Sarah and Karen, and others on the call actually. And we've just come to speak to you today about what we do in Yorkshire and Humber regarding migrants in vulnerable circumstances. So next slide, please. So just to give a bit of background, we set up our Yorkshire and Humber Migrant Health Network nearly 3 years ago, largely because of all the hotels that were being stood up. There was a real lack of communication and sort of collaboration around the health and wellbeing needs of people who were being accommodated in home office accommodation. So we spoke to our strategic migration partnership and our directors of public health, and we developed a migrant health structure under their structures, and we were very fortunate to have a director of public health agree to chair our network and take on the lead role on behalf of all our directors of public health in Yorkshire and Humber around migrant health. So I suppose I was quite keen for it to be sort of all formalised, because it would then hopefully have more of an impact. So right at the start, we worked closely with our strategic migration partnership, Home Office, our accommodation provider, who is MIA's up here, NHS England, and other commissioners and NHS providers, voluntary sector, local authorities, and what we really focused on initially was looking at how that common ground really, and having a shared purpose. There was a lot of tensions at the time, mainly between sort of Home Office approach and what others were doing. But I think, you know, we've come a long way since then. There's still tensions, obviously, and I think there will be for the foreseeable, but definitely come a long way. So we spent a lot of time raising awareness and encouraging action throughout this sort of health system. And now we have a clinical lead for migrant health within NHS England. We have named leads around migrants in all our ICBs and local authorities. In West Yorkshire, our ICS has become an ICS of sanctuary, and I've put the link in the presentation there because it's been a really good process actually, and I think is one that other areas are possibly looking at. What we've tried to do is look at advocating for the needs of migrants in other programmes. So ideally we want to get to a point, don't we, where we don't need specialist provision and we don't need to stand up these sorts of meetings, because the needs of vulnerable migrants and other inclusion health groups would be addressed within, you know, sort of mainstream work, if you like. So our structures now, next slide, thank you. Very busy, and I won't go through it in detail, but just to really highlight the bits in purple is our sort of health structure that we've set up in northeastern Yorkshire and Humber. So on the right there, we've got our migrant health network, which is chaired by our director of public health, and that feeds into our strategic migration partnership and our director of public health network. We also set up next to it a migrant health oversight group, because we were finding that there was a lot of still is a lot of wicked issues that we can't really deal with in the wider network. So on the oversight group, we've got all the sort of statutory partners really, and working at sort of a bit more of a strategic level to meet the needs of asylum seekers. And then more recently on the left, we've got the NHS response to healthcare provision for asylum seekers, and the links there with all the different ICB leads as well. So and then there's lots of interfaces at the bottom bit. So we meet with our local authorities around inclusion health, but often, the main conversation is around migrant health. So next slide, please. So some of the outputs that we have developed, you might not be able to see that very clearly, but we have a resource pack for, and this isn't just health, it's wider. So this was led by the Strategic Migration Partnership, looking at contingency accommodation, the process when accommodation stood up and down and everything in between, the communications, roles and responsibilities, etc. We've also developed a toolkit for nutrition, around nutrition and initial contingency accommodation, because obviously there's lots of concerns around the food and the variety being offered in contingency accommodation. We've got some, we've done a report looking at the oral health needs of inclusion health groups, and then we've also developed like an intelligence pack and Teams channel, and we've got a website with all our sort of resources on as well. Next slide, please. So finally, before I hand over to Kathy, so just some of the lessons we've learned, and I'm sure you learn an awful lot in the Southeast as well, because it's quite a busy region. So having champions in different bits of the system is just really helpful. So we've NHS England are brilliant here, UK HSA, and our Director of Public Health. So having sort of champions within those organisations is brilliant. So we do try and do everything in collaboration, with the wider health family and sort of wider collaboration as well. Children and young people and families, I don't feel we focused on their needs enough, or on safeguarding issues and making those links with other safeguarding work. So that's just sort of lessons for us, because it's quite easy to focus on the adult side of things, I suppose. We also are looking at developing better links with people with lived experience, rather than developing all sorts of things without even speaking to them. We've done deep dives, and the outputs that I showed you on the previous slide, they've all come from deep dives. So where we've looked at sort of nutrition and oral health, it's been quite clear we needed to step up task and finish group to explore it in more detail. As I said before, important to link with other programmes. So, it's not seen as sort of migrant health is a specific thing working in silo. Having regular data to keep stakeholders informed. So our Strategic Migration Partnership is really helpful there. And then development of guidance to support our ICBs and places. So I'm going to hand over now to Kathy, who's going to talk you through one of the outputs from the Migrant Health Network. Thank you.
Thank you. Yeah, so all my slides are appearing. I'll introduce myself. So I'm Kathy Wakefield. I am a Principal Screening and Immunisation Manager in Yorkshire and Humber, and I lead on vaccination and immunisation for Yorkshire and Humber. Next slide, please. So just a little bit of background. Appreciate some of this will be familiar to some of you, but won't be for others. So just in terms of where we're at with vaccination, it is recognised as kind of the second most important public health intervention, following clean water. So it does have a really high profile in the world of public health, as I'm sure you are all well familiar with. In terms of our delivery models and how people access it, it's not a simple structure. We have multiple providers for different parts of the routine immunisation programme. A lot of it's delivered through primary care, and that's from childhood through to adults. We now have community pharmacists that deliver a number of elements of the programme, and that's looking at being extended. Primarily from an NHS point of view, it's flu and COVID. From a private point of view, they're able to offer a number of other vaccination programmes. School-aged immunisation services that primarily do the adolescent vaccinations, but again, as contracts are renewed, we've kind of looked to extend the delivery that they're able to offer to other cohorts. So particularly where we're looking at things like MMR catch-up, preschool booster catch-up. So they're kind of expanding their remit considerably, and they also deliver the childhood flu programme for healthy children. Maternity services, again, is a growing area. So they have, since kind of 2009-10 into 2012, been delivering seasonal flu vaccine, pertussis, more recently COVID, and there are other programmes potentially in the pipeline for maternity services to pick up as well. So again, a growing area. And then some secondary care providers services. This is a little bit more sporadic. Again, some of them are generally offering flu, some offering other elements of the programme. But again, it's an area that we're trying to look at developing so that we kind of normalise vaccination and we maximise access as much as possible. I think one of the things to just highlight is the Green Book, which is everybody's go-to around immunisation. Quite often with a lot of the programmes, there are recommendations in the Green Book that are not part of the NHS funded and commissioned vaccination programmes. So there may be some queries from people where the Green Book suggests that somebody's eligible, but it's not part of our commission service, so it would be under GP core contract and core activity. What we do commission through NHS England Public Health is a Section 7A programmes, which is the routine national programme, and I'll just show what that looks like in a minute for people that are not familiar with that. So basically this covers newborn infants, young children at 1 year of age and 3 years and 4 months, the preschool booster, teenagers for various programmes, pregnant women and older people. We then have a selective vaccination programme that targets people that are at specific risk from specific infections. So neonatal Hep B, for example, where infants are born to mothers that are Hep B positive, and the neonatal BCG for infants that are identified antenatally as being at an increased risk of exposure. Next slide, please. Thank you. So appreciate you may not be able to see all of the detail of this, and I'm not going to go through it, but this is just to show you what the complete routine schedule looks like. So as you can see from that, we cover an awful lot of infectious diseases. There's an awful lot of vaccines in there. It is complex. And when you link that into the variety of providers for these different elements as well as, and sometimes there's a crossover in terms of what providers can deliver, and this does get changed on a fairly regular basis, so there's always something to keep us challenged. Next slide, please. So in terms of the migrant population and the risks and challenges associated with that particular group, again, some of this will be what people are already familiar with. But one of the first things that we have a challenge with is the different schedules in different countries. And what that means is that parents or families arrive in the UK, and as far as they're aware, their child is up to date with all of their vaccinations, not appreciating that our schedule may be slightly different, even if it contains the same diseases, same antigens, the schedule at which it's delivered in terms of number of doses, or the age at which it's delivered, or the frequency at which it's delivered, the intervals, it might be slightly different. So from a primary care point of view, when somebody registers, that's one of the first things that they need to look at. There's also a reported high level of vaccine hesitancy, and again, that could be for a number of reasons, as with any community within the general population. So it might be distrust, it might be lack of understanding, might be a perception that they don't need it, lots of reasons. But again, it's another line of kind of discussion that practitioners need to have to understand that and make sure that people have got the right information. Un or under vaccinated populations obviously gives us an increased risk of outbreaks, and we've seen that with the national diphtheria incidents, and also national and local outbreaks of measles. So again, a big challenge, and obviously the reason that we need to get people vaccinated as quickly as possible, so we get that high level of coverage within that community, that herd immunity. In terms of that schedule and bringing people up, as you can see, our schedule covers more than 17 infectious diseases, but it is complex. UKHSA have developed, and PHE previously have always had an incomplete or unknown, uncertain vaccination status algorithm. And that's the go-to guide, and I'll show that at the end just so that you know what it looks like. But that's the go-to guide for when you are having a conversation with a parent or an individual, because it might be if they're too old for the routine to fit in with the routine schedule, or they've had certain elements of it, then that tells you what they should have for their age at that particular point in time to give them maximum protection. Individuals are not always registered with a GP, as we know, and the other challenge around that is the length of stay that they have in various accommodation types, and that varies from a few weeks to multiple months, and they may move on at short notice. The challenge with that is that because they are often registered as under temporary registration with the practice, those records don't move on with the individual. So when they go to a different area, they're effectively starting from scratch, which is not particularly helpful. Whereas if the record with any patient in the general community, if they move practices, their record is transferred with them, so everybody can see exactly what the history is, where they're at, where there are gaps, those kind of things. As we know, English is often not the first language, so again, facilitating that through translation services, etc. Sometimes a distrust of the UK health system, or not understanding the UK health system, not understanding how it works, that it's free, what they're eligible for, all of these kind of things. So again, as Kathy alluded to, working with partners to kind of get the right information across, so that they've got that understanding. And then from a GP point of view, I think that there's often concerns and sometimes reality, but sometimes kind of misperception around the impact on them as a practice, as a provider, to deliver effective services to this particular population. What capacity have they got? what time have they got their workforce, the fact that they might have to go out to a site or an accommodation. They need to take additional staff. If they're going out as an outreach, they've got all of the transport issues, cold chain, all of those kind of things to consider. They probably need longer appointments to have the meaningful conversations, timing that with translation services, all of these things which just kind in a, you know, we all know how busy primary care is with their kind of all of their different competing priorities. So anything that they perceive to need extra support, extra input, extra organising is going to be a barrier to them. And then on top of that, as I've alluded to before, these individuals are often outside of the schedule, and they're unable to complete the schedule in the required time frame. General practice have something that they call QOF, it's quality outcome framework, and they're measured against compliance with that. And there's different thresholds, and there is funding attached to it. But what that aims to do is kind of ensure optimal delivery and performance to within certain areas of care. And if somebody arrives and there's no way that they can meet that requirement within QOF, then it will negatively impact on that practice from a performance and a quality point of view. So again, that often is something that practices are kind of a bit reluctant around. Next slide, please.
We've got about 2 minutes, Kathy.
Right. No worries. So in terms of the enablers, we've got an AXMA service fee, which practices are paid for. That's been changed so that they now get paid per dose rather than completed course. So that's been a big help. We no longer can claim money back from practices where they underperform, so that reduces the financial risk to practices. QOF's also been amended so that they can apply certain codes where if an individual comes and they're not eligible, they can't complete the time frame, they can apply a code and it will remove them from that denominator. So again, it's all helps to kind of help them to be compliant with their quality indicators. And if a patient's vaccinated overseas and they can provide that evidence, then they can record that, and again it counts towards their quality outcome. Next slide, please. So the key messages are there, and you can read those, but basically understand the characteristics of the population, map what services are available and how we can access those and work together effectively and collaboratively. Look at the models and interventions that work with that particular population, making every contact count, using community champions, looking at safe surgeries, all of those kind of things, and identifying what the constraints are so that we can tailor services to that particular population rather than looking at it as a just what we do for every population and every individual every time. Next slide, please. Making use of other community services, people that have links with these individuals, again, so that we can get the right messages across effectively. Use people that have got that lived in experience. We know the positive power of peer pressure, peer support, and they will often listen to those people more than they'll listen to healthcare professionals. It's never too late to catch up somebody on with vaccinations in line with the England schedule. You can't over vaccinate people. Assess the history as quickly as possible as soon as they arrive in the area. And basically, if there's no documented evidence of vaccination or if there's any doubt, then vaccinate them. Next slide, please. And that's just the incomplete algorithm, which, as you can see, is not without its complexity. It does take quite a lot of working through, which again does add additional time from a practice or a provider point of view, but an exceptionally useful resource. apologies, that ended up being a bit of a rushed whistle top stop, but happy to take questions.
That's fantastic, and a huge amount of detail there, which I think when we get the slides, you may get some questions both from colleagues around the southeast and further afield, I'm sure. Tremendous stuff there, and certainly some things for me from a Portsmouth perspective to take back on the vaccine side, because we're looking at some of that in detail at the moment. Thank you ever so much. Can I just take this opportunity to thank all of our speakers today for the brilliant contributions. It's been fantastic, and thanks to everybody that's stayed and lasted the course of the ambitious 4 hours that we've been together today. It's been phenomenal, and we thank you for all your contributions. So for this last kind of 15 minutes or so, we just wanted to give you an opportunity to reflect on what you've heard today, and have a chance to contribute on if there's anything you'd like to say about how we as a region might want to take some of this forward. If there's anything you've heard today that's kind of flagged for you that you think we might want to focus on more in a future session in a bit more detail, or if there's something perhaps that we might like to work more closely with our SNNs with. I know something came up in the maternity parallel session that colleagues were keen to look at in terms of evaluating some work there and looking at how we can make sure we maximise some of the pilot work happening, so that we can share some of the learning from that. But it's over to you really, in terms of some reflecting on what we've heard today, and if there's key things or stuff that you'd like us as a network to take forward in a more focused way, or generally worked together on going forward. I've lost access to the chat, so I can't see anything, so please do raise your hands if you want to contribute. Becca.
Thanks, Emma, and thanks for your brilliant sharing today. Not an easy task. I just want to build on what you've said, really, and I say this not just from an AHSN, but from having commissioned mental health children's services for a lifetime. I've had some amazing work today, and a lot of the work that have been pilots. So sustainability of some of this work isn't always guaranteed. So a real urge to ensure that some of the impact and the evidence base is sat there. Some of the we know it's brilliant work, but the invest to save kind of modelling, because whilst these pilots are fantastic, if the funding's only for a year, it not only raises expectations, it also, we also end up having to start again and set up these initiatives all over again. So that's one, evidence base and sustainability. And the other thing for me is it's been brilliant today to share some fantastic practice, and it's just how do we ensure that we share across the region the work that's often being done in specific geographical areas, but we could learn, and today's been great, but there is an opportunity to share some of those kind of key practical toolkits and resources too, and the learning.
Yeah, absolutely agree, and I think there's definitely some things we can do together around that evidence, gathering that evidence, really helping our ICBs and our local places build on that short-termism and embedding the sustainability and future-proofing some of the great stuff that's happening. So would really value how we kind of continue the relationships we've got locally and across the southeast to build on some of that and learning how we might do that better as well, because it's patchy, I think, in some of our places. So yeah, we definitely value that and absolutely agree in terms of sharing. So this is one of the networks and the way we can do that, and it's how we maximise on this network's ability to share some of the good practice, and whether we build in an opportunity to focus on a particular bit of migrant health periodically, to really hone in. You know, it's been a very full-on day to day, but we might want to hone in on a particular area of service or whatever, where we can really showcase some of the good stuff that's happening. Lisa.
I'm sorry, it's me again, but I just had a point that the document that came out about a week ago from Pathway and Groundswell and the King's Fund that looked at the 7 ICBs and how they were the pockets of excellence model, that they were describing that in great detail about inclusion health and about the risks that we have to depend on pockets of excellence. Yeah. I think that's a really good piece of work that that I haven't got the link here but if somebody could find it and share it in the chat, I think that people would find that really absolutely pertinent to what you've just been saying about sustainability.
Yeah, definitely. And I know Hampshire, Isle of Wight and Sussex were involved in that first round of King's Fund stuff. So definitely some stuff there. Pockets of excellence came up a lot in our conversations as part of that King's Fund learning set work. And absolutely sustainability is crucial. Any other comments or points anybody would like to make? No? Wonderful. Oh, Lindsay.
Just a microphone down. It was just a quick thing at the end, just about where we might be sharing this recording. So I think there was probably clinical colleagues that I invited that I imagine couldn't come for all of it or couldn't attend. So it'd be nice, perhaps, if we can share some of this recording. I'm not sure where it's going to be shared or how widely it's going to be shared, but some of our clinical colleagues could perhaps dip in to listen to some of the sessions. I think the sessions at the beginning are amazing, about kind of setting the scene, really, really important, and safeguarding. So it'd be nice to be able to share some of this learning.
Yeah, definitely. I mean, it usually goes on the futures.
So
NHS futures.
No.
No, sorry, Karen, go on.
It goes on the South East Clinical Network's website, and Olivia has popped that in the chat already, Lindsay. So people can click on that, and that's where the presentations will be uploaded and the slides will be shared as well afterwards.
Perfect. See, I'm behind the times already. I see a hand, but I can't see whose it is. Sean.
Yeah, I was going to say, I think it's my hand. Just to say thank you very much for today, everybody who's delivered presentations. They've been fantastic, clear, concise, to the point. Lots of things more understandable for me now. The concern for me, picking up on what Becca's just said, same thing. There's sustainability, but more for, I'm in Windsor and Maidenhead, we're part of Frimley ICB, and we all seem to be running around in our own little silos trying to fix things and plug holes in dams. So there seems to be such a discrepancy just across the southeast, so who knows what it's like across the whole of Britain. But you know, something about that working, you know, broader working together and sharing good practice, and you know, leadership from the top, really, about the expectations of the NHS, primary care, local authorities, what are all different roles are within this. You know, it seems that it's just being left to some really passionate, committed people to find a way through it, you know, like hacking through a jungle. So anything that we can do like that to kind of come together and you know, make life easier for us as professionals and make services better for, you know, it's been said many times this morning, people who are traumatized, and we're almost adding to their trauma rather than making it better, whilst trying to make it better. So yeah, but thank you, it's been excellent, really. Thank you.
Absolutely agree. Vicky, do you want to come back on that?
Yeah, just to not to keep everyone much longer, but to echo what Sean said, really, and these sorts of areas are really at risk of burning staff out.
Mm.
So I think it's great about sharing good practice and things, but also there is something about supporting staff.
Yeah.
And that even if we can't change things, a bit like that point earlier about legislation and trauma-informed practice and things and organisations, but there's something about just being able to recognise and share the fact that there's some things we can't change and they're just really wicked issues and difficult spaces to work in. So I think it's really important to recognise that and have that community where we can sort of support each other, really.
Yeah. And Karen's kindly forwarded me a picture of the chat, and Adele's put in a really helpful thing about harnessing talent amongst our 51,000 migrants who have many talents, a lot of which will be around healthcare skills and experience. And I know certainly in Portsmouth we've got a lot of stuff happening around community champions, a number of whom come from those communities, and we're looking at how we can develop apprenticeship programs right from the beginning through pathways through into health and social care roles across the apprenticeship pathway. So, you know, looking at things like that I think could be really good in the future as to how we can really support migrants who want a career and who especially have these types of skills going forward. So it might be something we want to focus on in the future too. Anything else anybody would like to say before we come to a close today? No? I'll just say a final thank you very, very much to everybody for all your contributions today. It's been really valuable and a fantastic session. Thanks to everybody that's organised everything, Olivia, Sarah, Karen and others. Thanks ever so much, and we will see you again soon.
Thank you. Big thank you to Alec behind the scenes managing the slides. Safe pair of hands. Thank you.
Absolutely. Thanks very much for joining this session, everybody. So this is on dental and oral health, and we've got a couple of speakers. Thank you for joining us. Just deal with those notifications. So we're going to have Sarah Hutchins from Dentaid, who I'm hoping is on the call, and then also Ifan George and Sarah Buckingham from Oxfordshire Community Dental Service as well. Ifan, I don't know, would you like to go first? Oh gosh, we've still got people coming through.
Yeah, I'm happy to, if I don't mind.
Hi, Sarah. And Sarah's here as well. So hello, thanks very much for joining us. I was just mentioning names of people who are speaking, so thank you to our speakers for joining. We've got about 20 minutes, so about 10 minutes each, and then a couple of minutes for questions. We've got slightly over 20 minutes. And then I'm going to be kind of keeping us all to time because we do need to obviously rejoin the main group back again by 1:15 to ensure that we can listen to the final presentation as well. So we were just saying about George going first, perhaps, going first, if that works okay. And do you want me to share your slides, Ifan, or do you prefer to do it yourself?
If you could do it, that would be great. Thanks, Sarah.
Yeah, absolutely. I will just get them up and I'll hand over to you. People can see them. Oh. Sorry, I lost my screen then. Great, so hopefully they're showing. Just trying to turn it into a slideshow. There we go.
There we go. Okay, so hello everyone and welcome to this short presentation on addressing dental and oral health needs in asylum seekers and vulnerable migrants. My name is Ifan George and I'm a senior dental officer with the Oxfordshire Community Dental Service, and I'm joined by my colleague Sarah Buckingham. who's a specialist in special care dentistry. So thank you for the invitation from Olivia Falgarak-Jones, and we'll go through what we found. So the aims and objectives for the session are to understand the prevalence of dental caries and why dental health is important with asylum seekers and vulnerable migrants, explain how examinations were organised by our service, and we're going to discuss the oral health habits of asylum seekers and vulnerable migrants and how they may be managed in particularly Oxfordshire in future. So a little bit of a background, we were looking at under 18s in this cohort. So generally with school children, dental caries is the world's most common disease, with a massive majority of patients experiencing dental caries. We can move on, thank you, Emma. Awesome. Sarah, sorry. And then particularly with refugees and asylum seekers, again, there is a large prevalence of dental caries with this cohort. So there's been multiple studies done. This particular review looked at 8 studies, and it found between half to all patients experienced dental caries, compared with 3 to 65% in general health studies. And then two additional studies looking particularly in children in the United States versus US nationals, and then a national oral health survey on refugees was conducted in 16-17. And if you press next, it will just bring up a review. So we measure decay or holes in teeth in decayed, missing and filled teeth. So the average refugee of a 3-year-old had an average of 2.6, compared with German resident population, which had less than 1. And then for 6 to 7-year-olds, that was increased to just over 5 teeth, compared with just under 2 teeth for German residents. Next slide, thank you. So moving on to UK dentistry, there's been a number of issues surrounding NHS dentistry and a shortage, such as leaving patients stranded. So these issues existed pre-pandemic and were exacerbated by the closure of many dental practices due to the height of the pandemic. And this obviously made a backlog of patients. And we're also looking at a time when dental providers are moving away from NHS dentistry and again reducing capacity. So we've also got our own deficit for NHS dental services, and hopefully you've seen some of these articles in the news recently. Next slide, thank you, Sarah. So in 2022 we had the Buckinghamshire, Oxfordshire and Berkshire West Integrated Care Board took over responsibility for commissioning of dental services from NHS England, and this ICB approached our service because many asylum seekers and vulnerable migrants housed at a particular hotel were complaining of dental pain, and especially an increased level of dental pain in children. Next slide, please. So we set up a day to go to the hotel, and this was in a small hotel in Witney in Oxfordshire, and that was conducted at the end of May of this year. Next slide, please. So the hotel actually opened to asylum seekers in November of last year, and houses asylum seekers from 10 countries. So you can see just a map of where they're coming from. So Albania, Iran, Iraq, Libya, Georgia, Honduras, Eritrea, Syria, Kuwait and Afghanistan. Next slide, please, Sarah. So the population of this particular hotel speak 13 different languages, some of which you can see here, and the number of asylum seekers and vulnerable migrants was 200, with around 64 of those being under 18. Next slide, please. So the team was 2 2 dentists and 2 oral health practitioners. We also had support from Dr. Jayanthi John, who's a consultant in public health and dental public health from the NHS England, working with the South East. Next slide, please. And then this is our setup, and then you can move through. There are some labels that show how we were set up. So we have clinical waste, patient chair sits opposite with a light. We've got an operator chair and then charting sheets and an assistant chair. So this was a converted hotel room where the bed had been removed. And yeah, quite a basic setup. We also use disposable mirrors and sterile mirrors and disposable gloves. Next slide, please. So we sent out consent forms in advance for patients or parents and guardians to complete. So of the 63 consents that we sent out, 57 of those were returned, and all of the consent forms that were returned wanted treatment. 5 consent forms were not returned, and on the actual day, about a fifth of patients were either not brought, ill, or not in the hotel or refused. So on the day we saw 44 children. Next slide, please. So dentists were calibrated prior to the session so that we scored equally. Each patient had an examination assessment sheet completed, and especially for the parameters at the bottom, so the treatment needed and urgency, we tried to standardize ourselves for this to ensure that we were recording accurate data. Next slide, please. So the results were around 60% of the children had visible decay on a quick examination, and this is compared to some similar school examinations that we did recently, which was around 25%. So a much higher proportion of these children have decay. Next slide, please. So a total of 8 children were deemed to need no treatment. Just over half were considered appropriate for treatment with the general dental service, so your high street dentist. And we found that we felt a quarter of these patients would require treatment with a community dental service, either due to their dental anxiety, being lack of cooperation if they were quite young, or if the treatment required was extensive or complex. 6 children were assessed to need sedation, and that's usually with a community dental service. And then 1 child was deemed to need treatment under general anaesthesia, which is going to sleep in a hospital. Next slide, please. So reflecting on the day, what did we learn? So prior to being sent to the hotel, there was some miscommunication as to the origin of the patients. So the dental team were told that the patients were Ukrainian and would have good understanding of English. So, but actually attending on the day, there were no Ukrainian refugees, and English was difficult to communicate in many cases. Most of the time it was actually the children interpreting for the parents. So in NHS dentistry, each patient must have a form called an FP17 sign, which is a consent form. And this was difficult to achieve, again, due to communication difficulties and trying to get the patients to actually understand what they were signing for. On the day, we didn't have much administrative support, and it was good that the Jayanthi John was able to help with tasks, and the added difficulty of we were going in to assess the need of treatment, but actually providing that treatment was a different story. So next slide, please. So moving forward, hopefully this group of patients will be able to access dental care. There are, of course, issues surrounding competing priorities, such as their general health, and patients that we already have waiting lists for who are vulnerable as well and requiring treatment. Where do we sort of slot this cohort of patients in? So in June of this year, the ICB in Bob actually gave out an expression of interest for flexible commissioning with general dentists to try and have vulnerable patients such as these seen. So 28 practices signed up again around Oxfordshire, Buckinghamshire and Berkshire, and it's designed to provide additional access sessions to support those who have faced difficulty, and that would include asylum seekers and refugees, those in the armed service, looked after children, and those who have been infrequent attenders. And again, this might be an opportunity for the general dental service to work alongside the community dental service, and perhaps with either facilitated partnerships to reduce waiting lists or reduce waiting lists being lengthened. So next slide is the last slide. It's just a list of thank yous to everyone who helped involved in the project, and thank you also to listening, and we'll welcome any questions.
It's brilliant, and thank you so much for taking us through that. I'm going to ask colleagues if they don't mind popping any questions in the chat, so we've got time to cover the other talk as well, if that's all right. And and we might have some time at the very end. But thank you. That was really, really interesting, really good to hear about. So thank you for sharing. I'm going to move on to Sarah from DentAid, and similar, Sarah, would you like me to share your slides, or do you prefer to?
Yes, please. Thank you. That'd be great.
Get them up.
Okay, so I'm Sarah. I'm the clinical manager for DentAid, the dental charity. We have been working quite closely with some agencies and local authority treating patients such as refugees and asylum seekers. Next slide, please. So we run an outreach dental clinic for people experiencing homelessness, survivors of abuse, families in poverty, refugees, cancer patients, people recovering from addiction, and communities where people are struggling to access dental care. DentAid, the dental charity, has several mobile dental units and one static. Our vehicles travel the country, visiting soup kitchens, hostels, community centres and volunteer dental professionals, providing a dental service, treating oral health and giving oral health advice. Our impact, the dentist has built up my tooth at the front, and now it looks like a proper tooth. Their patients are generally a lot happier when they feel that they can physically see something, and we see this quite a lot actually with refugees and asylum seekers, because their expectation most often is that they will be treated and they can have everything that they need. Obviously, we're working alongside the NHS. We're not competing against the NHS, so we have limits. Can we have the next slide, please? So, as I say, we work up and down the UK, and a couple of areas that we have worked with is Napier Barracks, which is currently being used to house a few hundred refugees and asylum seekers. And that's where we have our static trailer. And so we operate currently with a mobile, the trailer's been taken to the site, and we have a volunteer dental team and dental nurse who are running that clinic. Well, this was previously, and we had that contract for 2 years. We subsequently now have just been given that contract to run for another 2 years, offering the same kind of service. And primarily what we're dealing with are the challenges of language barriers, follow-up aftercare, the trust with the patients, the high needs of the patients, dealing with crowd control, and the reception from the local community. So for Napier particularly, we got told to stop operating because the locals in the area felt that it was unfair that they can't seek dental care, and we have been asked to come in and treat the refugees and asylum seekers at Napier Barracks. And, you know, we absolutely appreciate that that is a problem up and down the UK. So it made it very difficult. And unfortunately, we had to terminate, or we were asked to terminate by an agreed date to ease what was going on in the community, because unfortunately, the patients live in that community. But we have now gone back and we realised that we still have those same issues, but we're kind of working a little bit more discreetly. We've not advertised that we're going back there. And the kind of things that we're seeing is still the same as it was previously, which is the language barriers. And sometimes we're very fortunate that we have security who speak the language, so it makes it a lot more personal, or like most of us having to deal with language line, and sometimes that can delay a next patient's appointment. Or if you've got multiple patients with multiple different language barriers, it means that you're often waiting for somebody to be able to do the translation. And although most of the patients, I will say, actually have a translation line on their phones, which is brilliant, you know, that they've taken that initiative. But most of the time, the expectation is something that we can't always meet. And we're finding, particularly with refugees, because in most cases, they're only living in their accommodations for very short times, it's very difficult for us to then, if we need to refer to secondary care, where do we refer to? Because most often they might not be in the same catchment, the GP is not the same, or for whatever reason, they're no longer on the radar. So it can be very, very problematic for patients to get full dental care, which they absolutely require. Can I have the next slide, please? So, as I said, we did a 2-year project previously, and it was in partnership with the Home Office and NHS England. And at this point, we did have to terminate because of the complaints from the locals. We did 19 visits and 166 patients were seen, all received soft tissue checks, oral hygiene, prevention and screening for oral cancer. 114 fillings, 42 extractions and 25 scale and polishes. Can I have the next slide, please? And we also worked at Gatwick, which was a few hotels scattered around. Both of these sites are all men, and you can see the comparisons here with what was needed treatment-wise to what's been given previously at Napier. So we only did 9 visits at Gatwick, 80 patients were seen. All received the same screening, oral hygiene prevention and cancer screening, 43 fillings, 28 extractions, 7 sealants and 17 scale and polishes. So the comparison here is that within a smaller group, when we visited the hotels, their needs actually were somewhat higher. And because of the way that we work, because we might only be going back to that hotel one time, we try to allocate 30 minutes per patient to try and get as much as we can done and stabilise within that time. Unfortunately, 30 minutes is not always enough time. And as I said, the problem we have is if we did go back to that hotel, unfortunately, that patient might not have been there. They might have been moved on. So the main concerns that we have at the moment is it's the follow-up. It's what other provision are they getting once they leave that hotel or the Napier barracks? What secondary care can they get outside in community? And that's obviously always going to be a concern, because we can do what we can, but sometimes if they're being moved on, and sometimes we're finding that it's 60 days, it's a very quick turnaround in a very, small time frame. So we do find that patients often, we are just treating them, getting them out of pain. Sometimes just doing a scale and polish is all they require, because they don't always want to have their teeth removed. The other thing that we've encountered is in the Afghan community, a lot of patients were having restorative or bridges and crowns as prevention, because they were led to believe that if they had teeth removed and have a fixed appliance put in, then their teeth problems weren't there. There weren't going to be cropping up in the future. The youngest that I've encountered was a 14-year-old girl who had 2 crowns. So, and they were had post and cause in, so she'd had extensive treatment done at 14. So the concern now is that obviously the NHS is having problems with access, and we can't do always any fixed appliances or dentures because we don't see the patient enough to be able to give them that treatment. And obviously in community there isn't that resources. So those are the kind of things that we are struggling with at the moment. But, you know, hopefully with these new schemes that are coming in, this will change, and we are hopeful that that is the case. Next slide, please. I think that's it. And there's our details. Any questions, please ask.
That's brilliant. Thank you, Sarah. Really interesting to hear. I had a really quick question myself. It's just around, do you give the patients, individuals, like details themselves that they can take, sort of like a record themselves, just for kind of,
so what we do is we have, so depending on which clinic we have, we either liaise with their care support person and the patient and have to get consent to share that information, which sometimes is a barrier in itself. But we write it down and we get them to, you know, to explain what treatment they've had, what treatment is recommended, so that when they do get moved on, we also, if we feel that it's complex, I'm happy to print off their x-rays and give that to them so that they can take that to the next dentist. Unfortunately, I have also encountered that we've gone to a hotel and then we've moved to another hotel 6 months later and I found the patient there again. So, you know, we can now appreciate that they are going around and, you know, in a very close proximity, but they recognise us, and usually they've got the paperwork with them as well. So, you know, it's great that they still recognise that they need this treatment.
Yeah, no, absolutely. That's really helpful. I've just popped the slide back up with your details because somebody just asked for them. So, and really helpful overview of some of the challenges and work that you've been doing.
Thank you.
Unfortunately, we're a bit, we're so tight for time, which is such a shame because I'm sure we could get really into some of the discussion around here. But we do need to head back to the main meeting. I'm just posting the link in the chat, but in theory, it should work. If you kind of leave this meeting, then your original meeting should be still in, should resume. But it is the original link. So if you find you've been kicked out of it, then please just join how you did originally, or potentially try this link in the chat as well. So hopefully everybody finds their way back. So we've got a really interesting couple of speakers to finish with as well. So thank you everybody for joining, and thank you very much to both of our speakers as well today. Really appreciate you sharing your work as well.
Just to say, apologies, our inclusion health midwife wasn't able to be here today, so she's pre-recorded it, but she sits in our team but across systems across Surrey and Sussex. So it's a lot of this work is very much about working across boundaries and systems to make everything a bit more joined up.
Good morning, everyone. My name is Mary Claire Chapman. I'm going to really quickly talk to you about maternity services for asylum seeking women in Surrey Heartland and some parts of West Sussex. I'm really very sorry I can't be with you today, but I'm hoping that Lisa Gavin, service manager for the team, is here so she can answer any questions and fill in any gaps. So here in Surrey and Sussex, we have a pilot role going on at the moment, which is what I'm doing, of health inclusion midwife role. You can read the background to the role on the slide, and the purpose of the role is really to lead on identifying the needs of socially excluded women and birthing people. So a really big focus within that group of women is asylum seekers and refugees. So in midwifery, we haven't traditionally had roles such as health inclusion specialist midwife, so I just wanted to briefly outline the rationale for the role. In recent years, we've seen a huge increase in the numbers of asylum seeking and refugee women who are accessing maternity care in the area. And this was something new, and I think services didn't quite know how to cope with it, and there was a lack of cohesion and organisation. Also, and most of us will know this, there are huge disparities in perinatal maternal health within asylum seeking women and refugees. There are higher rates of maternal death in the perinatal period, higher rates of preterm birth. Also, the complexity of some of these women, not only is their health needs sometimes complex, they can book late, they come with health conditions that may not have been managed very well during the journey to the UK. Also, they can experience poorer mental health as a result of their journey and of their circumstances. There's the added pressure of housing and different locations being used. So there are a huge number of multiple agencies and services who can get involved in the care and support of asylum seeking women and refugees. So I just wanted to outline some of the key issues and risks surrounding pregnant asylum seekers and refugees, and these are just a few. So I think right up there, and it's going to be no surprise, is the fact that this demographic of women are highly transient, particularly in one of the ring-fenced hotels. I'm talking about Airport Inn, which is designed to be a short stay hotel and appears to be dedicated to families and pregnant women. So women will arrive at this hotel, they will be straight from Manston and Western Jetfoil, and they will be there for an unpredictable amount of time. If they're arriving in the later parts of stages of pregnancy, so 6 weeks before their due date, they're within the protected period, so normally they will stay at that hotel, birth their babies and stay for a period afterwards. A lot of women are coming at earlier stages of pregnancy, and it's really very difficult to predict how long they will be staying at the hotel. Sometimes the turnover is really quite quick, and I think this is one of the real key areas of risk, because there's a temptation for services to think, well, they're not going to be here long, we don't need to do this, we don't need to do an assessment, we don't need to do a booking. And I'm not just talking about maternity, but unfortunately this is how incidents happen and poor care happens. I think it's really important that to provide equitable care, we are not depriving women of care just because they are so transient. There are particular health and social needs that are often unique to this demographic of women, or there are issues and needs that these are of high prevalence. So for example, I've said here something that's unique, and I'm going to give you an example of something that I've noticed from my own practice. Some of you may know that as midwives, it's part of our role to do carbon monoxide testing at booking and at 36 weeks. And this is to detect whether women are smoking, and also to see if they live in an area of really poor air quality. And what I've found recently is that I'm getting high readings in women who don't smoke, and I do believe them. I don't think they are smoking. And when I've probed a little bit deeper, it's becoming apparent that actually the reasons for the high reading are as a result of this journey that they've had across, it could be across the Sudan, for example, and then up through Tunisia, up through Europe. So a really long journey where they're being exposed to passive smoking from other cigarette smokers, but also from fires that are being used to cook food and to keep warm. So that's just an example of something that I'm noticing. And we know that higher carbon monoxide levels can influence the growth of the baby and potentially lead to preterm birth. Other conditions that affect these women disproportionately, we see really high levels of psychological trauma, and sometimes that the reason for the trauma is the reason for the women seeking asylum, so really high levels of women who've been raped, but also the actual journey itself highly traumatic. I've had women telling me they've given birth in storage containers, they've been abused by the people who are transporting them. There are issues around missing information, so when women and their families come from Manston, as we know, there are no NHS numbers, which makes the process very difficult and means there are delays in getting sometimes the hospital numbers for women so that they can be booked. If they have had any care at Manston, or sometimes they receive care at a maternity unit in Dover, often there is very little evidence or information surrounding that care other than what the women themselves can tell us. There has been confusion around what the hotels are expected to provide, for example, transport, feeding equipment, and confusion around the pathways of women, how to refer into maternity care, and just general barriers to equitable care, such as the transients, which I've already mentioned. Of course, where there are different languages spoken, that's always going to be a huge barrier. And then it's not just that these families and women have limited English, it's also that quite often they have very low levels of literacy as well. Until recently, we've had very little specific data surrounding the experiences of these women as well, so it's very difficult to monitor and audit the experiences and outcomes of this demographic of women. So in order to mitigate against the risks of the transients of pregnant asylum-seeking women and refugees, these are designed with the help of Laura Weatherall. I designed these pregnancy transfer cards just so that women, when they move to a different location, can have a safe and effective handover of care. They are designed to be credit card size, so very small, can fit in the back of the phone or a wallet, and they can be handed to either health professionals or the hotel staff to ensure that the women book for maternity care, and any really key information is handed over to the new maternity providers in the new area. So I wanted to demonstrate on this slide how a really key part of the health inclusion midwife role is working with the different services and making connections so that pregnant asylum seeking women can have really effective and cohesive care. And I'm not going to go into each and every agency which is here, but you can see there are a wide variety of agencies. And as I mentioned at the beginning, although health is what we do, health is really important. It's really important that we don't have tunnel vision, and you can see here that there are services such as housing, also the VSCEs, which we work really closely with and have proved an invaluable support. So this referral pathway has been developed to ensure that women, when they are asylum seekers or refugees and they disclose a positive pregnancy test or think they may be pregnant, that they get a timely referral into maternity care. Amongst this demographic of women, often they end up booking late for the maternity care, and a lot of the time this is due to the transient nature of their lives. Sometimes it's because booking for maternity care just isn't seen as a priority, and the importance isn't understood. It's also sometimes quite difficult for women to book in the traditional methods. So most women who book for maternity care will self-refer online. That's for obvious reasons. That's not always possible for asylum seeking women and refugees. So this pathway has been developed. So generally what will happen is that the ABC healthcare team will do health checks on any new arrival in a hotel. They will then follow this pathway and refer to the different teams depending on where the woman is living. This pathway has also been circulated to the accommodation providers as well, because sometimes women will disclose a pregnancy to people working at the hotel. And I did joke to Lauren that I thought this would be, because I dropped laminated copies off to the asylum hotels, and I did joke to Lauren that this would be used as at best it might just be used as a coaster for cups of tea. But actually, when I was at Copthorne the other day, I did notice they have a big board by the entrance and this was on there, so I felt quite pleased. And I have had feedback from ABC that this is really working for them, and this is actually really helpful. There has been a lot of confusion around the transport requirements for the hotels, and this leads to cabs being missed, women DNAing appointments, or waiting at hospital for long periods of time for cabs back to the hotel. So this pathway was developed and sent round to all of the trusts in Surrey Heartlands to try and relieve that confusion. I held some really productive and interesting focus groups in one of the Afghan hotels, and the women were remunerated with little gifts and some vouchers. You can see some pictures here. In order to address the issues around having accessible information for women where there is a language barrier, I've designed a Padlet which can be used by all of the trusts in Surrey Heartlands, in fact probably any NHS trust in England. It's very easy to use. The midwives can access it on their phone or on a laptop, and the information can be either printed off and given to women in a paper form, or sometimes women prefer to have the information just texted or messaged to them on their phone. And from my focus groups, I know that different women prefer different things. Some women have said to me that they like to have something on paper because then it's there for them to access whenever they want. So I'm just going to very quickly demonstrate the Padlet. So at the top are all the languages. I'll just scroll through so you can get an idea of the languages that are available. Also, just to note, all the resources are in English as well, so that midwives, health visitors, nursery nurses, doctors, whoever is using the Padlet knows what they are giving out or what they are discussing with women and birthing people. So I've put most of the commonly used languages that we come across at the top. And then normally we'll go to Arabic. That's quite a good example. I've tried to order it so that the antenatal information is at the top, and then people can scroll down and see what's available. You'll notice here there are some videos. I'd say there are a high percentage of the women who use our services who have very low literacy levels. So for that reason, where possible, videos have been included, so they can just play the video on their phone if they have one, which most of them do. And there's a really wide variety of resources available. I didn't just want to cover the traditional, very health focused topics. I wanted to include things like domestic abuse, how to access the NHS, for example. So people can just click on whatever resource they feel that they need and they want to talk about. For example, a video about epidurals here, and they can then open the post and then they can send it or print it depending on what they require. Let's just pause that. Please do feel free to scan the QR code and have access to the Padlet. So some other work which has been done, I've been collecting some data around some of the outcomes surrounding asylum seeking women and refugees, such as rates of preterm birth, instrumental birth and infant feeding, and there were some interesting results in there which I haven't got time to go into now, unfortunately. We will be starting to have bi-weekly safety huddles with ABC, the healthcare team that visits the hotels, and this is on the back of a safeguarding incident where we realised it was actually really important to be sharing information with each other. I'm also developing a trust SOP for asylum seeking women and refugees.
I think that's the last slide, Lisa, and there's no sound on this one. Oh, you're on mute.
Sorry about that. And can I invite Lauren Chandler to chip in with me about this? So Lauren and I are matrix managing this new inclusion health midwife role, which has taken us a while to get this through various channels, because we saw the need for and the risk around pregnant women and the transience of the women through the hotels. So it's fabulous having this, and I have to say that Mary Claire has been all that we hoped for and more. Would you agree, Lauren?
You know, it's really fantastic to see this presentation with her showcasing the amounts that she's achieved in 6 months, not even 6 months.
No.
So, you know, and it's not just box ticking, you know, she's really engaged with the community and the link workers, and these are really meaningful, useful tools. And it's amazing sometimes how such a simple step can make such a difference for safety. As well as experience. So I mean, it's outstanding, and just the value of a role like Mary Claire's, where we know the need for these things, and but the stretch is so much within the clinical setting that you just can't get to these things. So it's been amazing to have someone as wonderful as Mary Claire step into this job and really perform in it. So we're very grateful to have her.
And I think that you're absolutely right. And one part of the key to this is about sharing our resources. We all know that in the current state of the NHS, resource is very thin. And what we have shown with both with my very small team, but also bringing in expertise and other groups is this notion of working across boundaries and with our partners and all levels of health is really what helps us to achieve this. So Mary Claire is working across West Sussex and Surrey. Our inclusion health team is funded by Surrey, but her post is actually being, it was the local maternity and neonatal system that originally found the money out of inequalities funds, because we've been arguing that this was a risk. So it's looking across, so she's employed by the hospital, Surrey and Sussex NHS Trust, but sitting in a community team and then working with our primary care colleagues as well. So I think this is a model that's very scalable, and it's actually looking at, and it's also very impactful as well.
Absolutely, yeah, and actually when we're saying this, that she's also supporting Sussex and Kent in sharing this work, and the reach is really great with it, and the example of how we can stop duplication in what we're doing work-wise and make sure that we're sharing resources. It's a real example of how we should be moving forward.
Yeah, I think that's the key. I think it demonstrates, doesn't it, that you only actually need a small amount of resource to coordinate efforts and change the way you work that makes a massive difference, because she's covering a huge geographic patch, yet she's managed to achieve a huge amount by fundamentally impacting across the maternity system to enable people to work in different ways, supporting these women in the way they need to be supported, with actually a small amount of resource.
And that's really, I think that's quite surprising for people, but actually
yeah.
I see that as really positive. Vicky, did you have a question for us?
I suppose it was more of a comment really, is about the funding, having been fortunate enough to spend a little bit of time with Lisa and Mary Claire, is the work that you're doing, is how many contacts elsewhere that are avoided, inappropriate contacts, because of that bespoke support that you're providing to those women and their families. And that's the measurable bit, isn't it? Well, that's the bit that's, I suppose, is difficult to measure, but there perhaps could be some predictive work about the savings elsewhere.
That would be really good if we can capture that.
And I'm thinking that that some of the conversation with Becca's team, actually it would be really good to get some robust collection of this, because we did a small piece of work around, it wasn't actually Surrey Hospital, but it was at the Royal Surrey, around missed appointments and the cost. And so we looked at some figures because of the problem with the transport and the Home Office providing the taxis to appointments. So we looked at the cost of missed glucose tolerance tests, consultant appointments, midwifery consultations, and sort of roughly to give a rough figure for how much this is actually costing the system. And we also see inappropriate ambulance call outs and things, and that's partly where GP appointments, all of that sort of thing. So looking at the really acute hotel with short stay is key, because that's holding the biggest amount of risk. And now that we know from the Home Office that they are actually funneling most of those pregnant women to this particular hotel, and having had some confirmation of that last week through Lauren's efforts to sort of really pin this down, that's giving us, in a way, the evidence that we need we can manage the risk, and we can identify it, and we can say, actually, this is where we need to look at the resource and how do we manage it. I will say Mary Claire also supports, as you've said, the wider maternity system, because she does a lot of work with supporting the community midwives and the hospital staff. So she seems to be everywhere at the same time. I don't know how she does it, but
We're going to be whisked back into the main room now, so hold those thoughts, and we'll come back to that when we have a general discussion. I think Alec might be telling us to go back.
We are ready whenever you are. I appreciate it's a very good discussion.
It is. Let's leave now and resume the call. The link is there if you can't join by resuming the call, but the link is there in the chat if you need it. Okay, let's rejoin the main group.
So yeah, welcome to everyone. I'm Claire Winside. I'm a consultant in health protection with the UK HSA South East Health Protection team. So I've been asked to come and talk to you about TB screening in migrants. So yeah, next slide, please. So just a sort of a bit of a summary figure of TB case reports and rates across the southeast. So that this is not just migrants, this is all our TB cases since 2000 to 2021. So you can see that there has been a fall over recent years, but a slight increase again more recently. But obviously 2020 was COVID, and that I think universally sort of saw a fall in cases, which is probably to do with sort of access to healthcare and other things. And it's sort of in 21 gone up to pre-COVID rates again. There's usually a bit of a time lag with TB reporting because of allowing for time for people to get through treatment and then sort of data cleaning and so on. So that's that. If we can move on to the next slide. So just a little bit about TB and migrants. So people from outside of the UK accounted for most TB notifications in England. I'm using England data here rather than South East because there was just sort of high level of detail on this at England level. So about just over 3/4 of cases in England were born outside the UK. Most from the Indian subcontinent and Africa. So top 5 countries of birth being India, Pakistan, Romania, Somalia and Eritrea. But to note that the increased risk of TB in migrants isn't just determined by that pre-migration exposure in a high incidence country. So particularly when you're thinking about like asylum seekers, you sort of need to think about the risk in the country of origin, the countries they've transited through, living conditions on the journey, and again on arrival in the UK. And all contribute to that increased burden of TB that's seen in this group. So those factors This can obviously include exposure to TB, HIV, malnutrition, barriers to accessing healthcare, immunisation coverage, poor living conditions, and stigma and marginalisation. Thank you. Just really illustrates what was shown in the last slide, that those rates in non-UK born populations compared with the UK born. That was fine on that. Move on to the next slide. This was Q3 data published this year, looking at proportion of TB notifications with various social risk factors. In this particular quarter, the most common social risk factor was actually being an asylum seeker. So that was 6.4% of adults aged 15 or older who were notified with TB and had information recorded on social risk factors. Data on asylum seeker status was missing in around 15% of notifications, so not complete. And obviously noting that there is fluctuation quarter by quarter, but it is an important risk factor. Moving on, just to flag really that there is a national TB action plan covering 2021 to 2026. It's jointly produced by UKHSA and NHSE. 5 key priorities there, and underpinned by actions for specific population groups, such as underserved populations and new entrants, among other population groups. Some measurable outcomes and indicators, and a focus on system-wide actions. For example, ensuring TB is included on prevention and health inequalities agendas. Next slide, please. So really wanted to focus a little bit on the TB Migrant Health Guide, which was updated in June this year, and makes very specific recommendations around active and latent TB screening in migrants. But just to note, it should also be read alongside the more general Migrant Health Guide, which does provide country-specific recommendations for other infectious diseases and, in fact, other things that you might want to consider in migrants, country by country. Thanks. Next slide. Firstly, looking at screening for active TB. So just to note, there is pre-entry TB screening for migrants who arrive in the UK via formal visa routes, and that's for active pulmonary TB. It includes a chest X-ray and a symptom assessment, and where appropriate, a sputum examination. And those individuals who are identified with active TB have to complete treatment before their visa is granted. It doesn't include testing for latent TB infection or for TB outside of the lungs. So that's for migrants applying for a visa to the UK, intending to stay for longer than 6 months and from a high incidence country. Sorry, can you go back to the previous slide there? Thank you. Obviously that's only for people who arrive via those formal visa routes, and thinking about migrants, asylum seekers and so on who arrive by unofficial routes, they're not going to be covered by that pre-entry screening programme, but they may well be from high incidence countries for TB or have experienced complex risk factors on their journey to the UK, so need to be considered for active TB screening. So the recommendation is that they're from high incidence TB countries, so in this case they're defining high incidence as more than 40 cases per 100,000 population, and you can find information, I think, I can't remember, it's in the Migrant Health Guide, but which countries those are. But if they're not covered by the pre-entry screening programme, they should be offered screening for active TB as soon as possible after arrival, and this should be initiated at the first point of contact with healthcare services or upon registration with primary care services. Next slide, please. So the recommendations as to what that should include, so for children over 11 and for non-pregnant adults, that should consist of a symptom check, a chest X-ray, and where appropriate, so that's when a person is coughing and able to produce sputum, a sputum assessment for TB. Children aged 11 and under, should be a symptom check at the first point of contact with healthcare, and for pregnant women, a symptom check and sputum examination where appropriate. Latent TB, evidence suggests that in low incidence countries such as England, most cases of active TB in migrants result from reactivation of latent TB infection, and that there has for a while been an NHSE funded screening programme for sort of countries, or sorry, not countries, areas of the UK where there are high migrant populations, high incidence for TB, that there's been a programme screening for latent TB, and there is evidence looking at that latent TB screening for those from areas with a TB instance of more than 150 per 100,000, so no different threshold for the active than for the active TB screening, but there's evidence that's cost effective. So moving on there, so the recommendation there is that screening for latent TB infection via a single IGRA test should be offered to all migrants aged 16 to 35 years old who've arrived in England in the last 5 years. And that's including where they've entered via other countries, and who've born or lived more than 6 months in sub-Saharan Africa or countries with a TB instance more than 150 per 100,000 population, that they've got no previous history of TB or latent TB infection, and you need to sort of look at assessment there for new exposure as well, to consider what screening is needed, and they haven't been previously screened for latent TB infection in the UK. You might want to, obviously blood test here, you might want to do this alongside screening for HIV, hepatitis B and C as appropriate, informed by the Migrant Health Guide. So just other things to consider from the TB Migrant Health Guide, just a recommendation around maintaining that long-term vigilance for signs and symptoms of TB in at-risk groups. So that does include the non-UK born, even many years after arrival, their families and others who've got links to endemic countries. To note also, non-UK born people are more likely than UK born people to get extrapulmonary forms of TB, so important to be vigilant for signs and symptoms consistent with that. To inform at-risk patients about the symptoms of TB and encourage them to seek prompt medical advice if they develop them, and to offer HIV testing to anyone who is diagnosed with TB. Next slide, please. So just a little bit about referrals. So there are TB specialist teams in all areas, going back there, sorry, comprising of specialist TB physicians, microbiologists, TB specialist nurses, that might include TB caseworkers in some areas, public health teams, and in London there's also the Find and Treat team. We have made use of them in screening for various incidents. Refer people early if there's a suspicion of TB. And for us within the health protection team, we support TB services in managing incidents and complex cases through risk assessment and advising on guidance. So we sort of bring everyone together for a joint decision making where we've got these incidents looking at who we need to screen. That's our email address there if you need to contact us about a TB incident. Thank you. Next slide. So just some useful resources on this slide, really. So some of those I referred to through the Migrant Health Guide. There were some specific recommendations made also around arrivals from Afghanistan and Ukraine. Yeah, and some general resources around TB. So hopefully the slides will be available afterwards with those links for anyone who wants them. And that's me. So shall I hand over to you, Rob?
Thanks so much for that, Claire. And hi, everyone. For those of you I don't know, my name is Rob Verrecchia. I'm another consultant in health protection in the South East Health Protection Team in UKHSA, and I'm one of our migrant health leads in the region. And we thought, just given that there have been a number of cases of diphtheria recently in newly arrived asylum seekers, we thought it'd be quite good to tack on a little update on the situation with diphtheria for those of you who are interested in these health protection issues to this meeting. So apologies I don't have any slides, but this is hopefully just a quick update on what's going on, and we should have a few minutes as well for any questions for Claire or myself. So just a quick reminder. So diphtheria is a bacteria. Some strains of it can produce a toxin which can be quite harmful. Other strains of it don't, and we're not very worried about them. When you have a toxigenic strain of diphtheria, it can cause usually two different types of illness. One is a respiratory type illness, and another is a cutaneous type illness where you get lesions. It's normally really, really rare in the UK. So in before these issues came up last year, we'd see kind of single figures in the UK. Last year, as we kind of got into summer, we started to see a lot of cases in asylum seekers, newly arrived asylum seekers. I think we had around 75 confirmed cases last year. And then it settled down as the new arrivals in small boats stopped over winter. And apart from one case right at the beginning of the year, we didn't see any until August. And since August, we've had a total of 7 confirmed cases this year, all in newly arrived asylum seekers. I think all in actually under 18, so all in unaccompanied minors. And most of them, fortunately, this year have been pretty well. Some with some lesions, some with sore throats, and often this is on a background of having other lesions, maybe wounds, other infections, and this kind of thing to kind of complicate that picture. The other tricky thing that we've seen this year in the presentations of these individuals is that 2 of them, when they've been tested, we found that they've had drug-resistant strains of diphtheria, which has required treatment with quite kind of specialist medication, a antibiotic called linezolid, which is a little bit trickier to source and prescribe. So that's complicated the picture a little bit as well. One thing I think is really important to note is that for certainly for all the cases this year and for pretty much all the cases last year, we can be sure that the transmission of the diphtheria occurred before they arrived in the UK, and that's just around kind of the incubation period and the timeline. So that's reassuring. We certainly haven't confirmed any secondary cases this year or last year. And our team, the health protection team, received notifications of these cases and are working locally to support and coordinate the management of those cases, ensuring they're getting the proper treatment, that the isolation is correct, and that any contacts they might have are properly identified where that's possible, and again managed appropriately. And that is through various things such as prophylactic antibiotics, testing, vaccination, etc. And I also wanted just to highlight that more widely in our organisation in UKHSA, there's work to support and advise various partners kind of around various aspects of this. So from a kind of a policy point of view, but also operationally. So we're working with colleagues in the Home Office, in such places such as Manston, looking at isolation facilities and how that works in practice, looking at how transfer processes occur when individuals need to move and are suspected of having diphtheria or other illnesses. So there's quite a lot of work going on in the background to try and prevent the issues that this rise in cases can cause. And apart from the management of the cases and that kind of wider advice that we've been giving, there's 2 other activities I want to highlight that are in place as well to try and impact this issue. The first one is that there's a recommendation from our national diphtheria team that every new arrival into the country, every new asylum seeker arrival coming through the Manston or the unaccompanied asylum seeking child route should be offered prophylactic antibiotics and the vaccine, regardless if they're a contact of a known diphtheria case. And this really is one of the key rationale behind this, is that contact tracing in some of these settings is basically impossible. So you can imagine trying to work out who someone will, if you find you've got a case of diphtheria, if they've been on a small boat, trying to find out who on that boat they would be a contact with when there's 80 other people, or similarly if they're in Manston in a marquee with 100 other people, contact tracing becomes basically impossible in these settings. And this is seen as a kind of a less perfect, but an alternative approach to try and manage that risk which exists in this population. The other activity which is started this summer is surveillance sampling. So there's some work trying to identify how much diphtheria there might be in people who aren't presenting to the medical services. So that's really thinking about who might be asymptomatic and yet carry the infection. And there's been some surveillance sampling in some of the unaccompanied asylum-seeking children hotels, and that's now finished, and now there has begun a surveillance sampling in the Manston site, so looking at kind of adults and the family groups, really to try and identify really, you know, how much is there out there which we haven't seen. And although those results aren't published yet and the kind of findings aren't shared more widely, I'm pleased to say that it certainly hasn't picked up lots of hidden diphtheria in a way that, you know, we worried it might have. So that in itself is reassuring. So they're the kind of key updates. So cases are up a little bit this year, not quite as high as we saw them last year. It's something we're very much kind of keeping an eye on and working with various partners, including I can see some on the call, to think about how best we can respond to this from a health protection point of view, but also kind of as a wider health family as well. So I'll stop there, and if there's any questions for me or Claire, I'm really happy to answer them.
That's great, Rob and Claire, very much. We've got about 5 minutes before we have to return to the big meeting. So, Nancy?
Thank you. Thank you, Rob. Nice to see you. Thank you for the update on diphtheria. My question is actually about TB, if that's okay. So I haven't looked at all the updated guidelines around TB, but I still have a concern about the focus on screening new arrivals who originate from a country with high incidence, considering, certainly from my point of view, on unaccompanied children, the type of journeys and the length of journey that they take to get to us in the UK. And they need actually to be more proactive and screen all new unaccompanied arrivals, which is what we were doing in Kent prior to the difficulties that we run into with the National Transfer Scheme. But I still have a concern that there is so much focus on those from high incidence, when actually land travel puts them at greater risk sometimes than where they come from.
Yeah, I'm not quite sure what to say about that, really. I mean, obviously, I wasn't involved in writing the national guidance, and I'm fairly sure they would have considered that sort of thing. But I guess it's challenging in terms of what, you know, how do you actually put a recommendation together that necessarily covers all those scenarios? I mean, the way I'd read it is, yes, you take into account their journey, and if you think they've passed through high incidence areas and you feel it's appropriate to screen, then that is that sort of individual risk assessment. I appreciate that's probably not an ideal situation. It's easier to have a blanket recommendation to screen them all, but I'm not entirely sure of the thinking behind, you know, how they came up with that guidance.
No, absolutely. I think it's never easy to write guidance that's going to take into account all of the different scenarios we meet on the ground. But I think it's very difficult for us to try and sometimes make cases for funding when guidance isn't supportive, as you can well imagine. And the other thing is, of course, about latent TB testing, and it took about 5 years. So that means we need to start thinking about those unaccompanied children who came in and are coming in, and how we set up a service to test for latent TB. So I will take that back to others who are on this call. Thank you very much.
Yeah. And I guess just to note, I mean, I think most of the focus of today maybe has been on asylum seekers, but obviously this is migrants, the recommendation. It's not just asylum seekers, so it goes a lot wider than that.
Dominique, did you want to come in?
Yeah, sorry, we've been very politely waiting. Thank you very much. That was really interesting. I had a quick question actually on very similar lines to Nancy, and really to develop my understanding around acute TB assessment. So obviously you mentioned the migrant and the TB guidance being that should be initiated at first point of contact or with primary care registration. Is there any assessment done for those with presenting symptoms at Manston or other points of entry, or is it less systematic?
Rob, do you want to take that one? I'm not sure the ins and outs of what they're doing at Manston.
There's not routine screening for active TB. There's at Manston there is obviously health. There are doctors and a health centre. I know that people can present there with symptoms, medical conditions, and they have identified a couple of individuals who I believe who were known to be on TB treatment, and I believe kind of restarted them on that. So there is kind of a process to touch on this if it's required when it's kind of barn door. But people stay in Manston less than 24 hours for the vast majority of time, so it's not an appropriate place for TB screening or identification really to be taking place. Certainly would be keen to see that kind of focus of that in kind of the next stage settings where people are for a little bit longer and a bit more stable.
Thank you, that's really helpful for my understanding. Thanks.
Thank you, everyone. We need to return back to the main meeting. I'm sorry that it's ended in a rush fashion, but also the next speakers are also touching on the immunisation guidance that's being developed for migrants. So the health protection aspect will continue in the next presentation. Thank you, Claire. Thank you, Rob, very much indeed.
Thanks so much.
Thank you. See you in the main meeting.